evening.
Good evening, everyone, and namaskar. So it's a great pleasure and honor to welcome you all for this exciting discussion that's called ONCOV 2026. As the name suggests, these are the clinical updates from the recent international conferences. I think there's a lot of data which is available, and thanks to Dr. Mukesh Bansal for preparing a nice agenda. With this, I will invite Dr. Mukesh Bansal, sir. He needs no introduction. He's a senior consultant, medical and hemato-oncologist at Alchemist and Ojas Hospital at Panchkula. And once again, a good evening from the organizing team. Dr. Mukesh, sir, with your kind words, and then we will start the sessions. Over to you, sir.
Yeah, thank you, Mathurji, for the nice introduction. Namaste, good evening. I welcome you all in the third edition of ONCOV 2026, clinical updates from recent international conferences. I'm looking forward to the exciting agenda, active discussions, and active participation from faculty and as well as learning for the students. I hope the speakers will adhere to the time limit. And with this, I will like to invite our first speaker, Dr. Akanksha Chabda, Senior Consultant and Unit Head Medical Oncology and Hemato-Oncology at Max Super Specialty Hospital, Mohali. She will be talking on elucidating nanopecli stories in India and the recent advances. Over to you, Dr. Akanksha.
So a very good evening to all. Thank you, Dr. Mukesh, for giving me this opportunity. And I'll be speaking on elucidating nanopaclitaxel stories in India and the recent advances. So are my slides visible?
Yes, ma'am. Your slides are visible. You can make a full screen and then over to you, please.
So it says the host is not allowing multiple sharing for this webinar. So I think my slides will not move. Or can you please share from your side? I'm okay with that too.
Ma'am, we were able to see your screen well. The slides are there. Tech team, can you help us out?
Yes, ma'am, you can share your slides.
No, it's not allowing. Na? It's saying that the host is not allowing to share.
Ma'am, अभी किया होगा उन्होंने. The slides looks blank. Okay, ma'am, just give us a minute. Daud, if you have the slides, if you can share from your side. Yeah. Ma'am, you just have to say next, 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 and next. That's
sure.
It. Over to you, doctor.
So I'll start with my presentation. So just a brief about the highlights of the evolution of taxanes in oncology, how the taxanes came into picture, and why are we using paclitaxel and docetaxel nowadays. So it all started in 1960 when there was some taxane was discovered, which was then extract from the bark tree, which showed some anti-tumor activity. But the first approval of taxane was there in 1992, wherein the paclitaxel was approved for metastatic ovarian cancer. 2 years later, its role came into the breast cancer, which was metastatic. And then in 1996, another taxane again got from the bark of the yew tree, that is European yew by the name of Texas, and from wherein docetaxel came into picture. And initially, it was approved in metastatic breast cancer. Then the paclitaxel indications in various other cancers came, such as the sarcoma, lung cancer, the high-risk early breast cancer, and ovarian cancer. Then came the combination therapy, but before that, docetaxel got its approval in metastatic breast cancer. And post that, the combination therapies, that is docetaxel in combination with capecitabine or paclitaxel in combination with gemcitabine, and again docetaxel in combination with prednisolone was there, which was approved in the metastatic prostate cancer. But all these were conventional taxane-based therapies. Then for the first time in 2005, we got the approval of first NAB taxane approved, which was approved initially for the metastatic breast cancer. And that's how the NAB or the nanosomal or the NAB paclitaxel and docetaxel came into picture. Next, please. So, why the need of this another or nanosomal based taxane formulation? This is because we had certain limitations whenever we use the solvent based paclitaxel, whenever we use the conventional paclitaxel, we have certain limitations because these taxanes are hydrophobic and they require particular solvents. This solvent is by the name of cremophore, and cremophore by itself is not inert. It has its own biological effects which actually alter the bioavailability of the active drug, which is paclitaxel. And due to non-linear pharmacokinetics, there is trapping of this paclitaxel, which is the active drug, inside this cremophore micelles, and that is why the availability of this paclitaxel inside the tumor tissue is reduced, and that is why the pharmacokinetics becomes non-linear, and that is why there is actually more of side effects and less of the tumor availability of this taxane. And also, if we try to improve this by the dose escalation, this above certain threshold has not shown to improve the outcomes in case of metastatic breast cancer. So the various limitations are there is altered or non-linear pharmacokinetic profiles, and because of hypersensitivity reactions, we have to give the pre-medication which involves the antihistamines and steroids. And despite giving all these pre-medications, still 40% of the people may have certain sort of side effects, and out of these 3% of the patients may even have life-threatening reactions, and that is why we need the newer formulations. Next, please. So, as I told that this cremophore-based paclitaxel has certain side effects which limits, and that is why we need formulation-free the paclitaxel or docetaxel, which can give us the linear pharmacokinetics and which can also deliver higher dose of paclitaxel inside the tumor tissue and lesser dose of paclitaxel inside the normal tissue to gain the therapeutic benefit. Next, please. So talking about the newer taxane formulations, we have now the cremophore-free paclitaxel formulations, which can broadly be classified into two categories. Either they are albumin-based or albumin-bound, or they are polymer-based. And this albumin-based paclitaxel, which is known by the name of NAB-paclitaxel, instead of cremophore, it uses human albumin as the carrier of paclitaxel. Next, please. So talking about this nanosomal or NAB-paclitaxel based formulation, now this innovator NAB-paclitaxel is complex nanoparticle. It is basically composed of two functional units. One is paclitaxel, which is the active drug, and another is, instead of cremophore, we have albumin, which is the biological component and which enhances the performance of this innovator NAB-paclitaxel. Now, as speaking about this, albumin is functional component of NAB-paclitaxel, and this NAB-paclitaxel has been approved by FDA in certain types of cancer, which we will discuss in the upcoming slide. And US FDA has also emphasized the criticality or the importance of this albumin-based paclitaxel and the importance of particularly albumin in this sort of formulation. Next, please. So talking about albumin-based copies of Abraxane, by Abraxane I mean it is NAB-paclitaxel. So as I told that human albumin is the biological product, but whenever we give this NAB-paclitaxel, different people or different population subset reacts in the different ways. Why? Because their immunological behavior is different. And why that is different? This is why, because we have different albumin source in various NAB-paclitaxel, and due to also minor differences in the manufacturing processes, that this NAB-paclitaxel behaves differently in different humans, and that is why it is important to use this particular one subset of NAB-paclitaxel or NAB-Abraxane or nanosomal particle, which we will discuss in the upcoming slides. Next, please. So because of this various restrictions that we have gotten from this albumin-based paclitaxel, we have focused on another type of paclitaxel, which is polymer-based paclitaxel, which is another newer taxane formulation. And this polymer-based paclitaxel can be divided into three categories. That means that we have three different subtypes of polymer-based paclitaxel, where one is paclitaxel injection concentrate for suspension, another is polymeric micellar technology, and the third one is paclitaxel nanoparticle injection, which is also polymer-based. So how to overcome the limitations? We have this polymer-based paclitaxel, which makes paclitaxel more water-soluble, and instead of cremophore, which was the solvent which was actually responsible for all the side effects. So this polymer-based paclitaxel is chromophore-free, and that is why all the side effects can be prevented. And this is also albumin-free formulation, and this formulation has better, side effect profile and comparable side effect profile, but without compromising the efficacy and safety. Next, please. So talking about the comparison of different nanoparticle or nanopaclitaxel formulations, one is PICN, which is the suspension of paclitaxel concentrate, which we have just studied about. This is the best, and this has also been compared with the paclitaxel lipid suspension and other two polymeric based paclitaxel, which we have just seen. So this has been compared with the innovator NAP paclitaxel, and it has been shown that if we talk about the Indian subset of patients, almost all three has been tried in the Indian subset. But talking about the dose, to compare the dose of innovator nab-paclitaxel, this PICN has shown the equal efficacy with the use of this similar dose, that is 260 milligram per meter square, which is given 3 weekly. But we have lesser of grade 3 or 4 neutropenia and lesser of grade 3 or 4 neuropathy by the use of this PICN based, which is polymer based paclitaxel, as compared to the innovator NAP paclitaxel, because if you see the percentages of neutropenia, this is 20% versus 12%, which is lower in PICN. And if you see the neuropathy, this is 17% versus 7%, again favoring the PICN based paclitaxel formulation as compared to the innovator, or as compared to other three, which is lipid suspension and other two polymeric based paclitaxel. So talking about the requirement of inline filter, which is not required in this PICN and also not required in the paclitaxel lipid suspension, it is just required in the paclitaxel nanoparticle injection, which is another polymer based injection. But talking about the infusion time, the best benefit is seen in the PICN. Why? Because the infusion time is just 30 minutes as compared to 3 hours and 1 hour in other three formulations. And also this is less cumbersome process. Why? Because we have only one step dilution which is needed in the mix-in for the use of this PICN, which is not available with the other use of other three polymeric based suspension. And talking about the storage, this all polymer based suspensions can be stored at the room temperature, which is up to 25 degrees, as compared to the specific temperature requirement, which is 2 to 8 degrees Celsius, which is required in the paclitaxel lipid suspension. That is why PICN based or other polymer based paclitaxel is better than the albumin bound or the conventional paclitaxel. Next, please. So talking about the use of this nanopaclitaxel in the various cancers, I'll start with the early breast cancer in the neoadjuvant setting. Next, please. So talking about this particular trial, which is Keynote 522, which we all know about, where the patients of early breast cancer, which were either node positive or they were either T2 and higher, which were node negative also, they were taken, which were non-metastatic, and they were divided into two arms, where one arm received the paclitaxel carboplatin plus pembro, followed by AC plus pembro, and surgery followed by the adjuvant pembrolizumab. This was compared with only chemotherapy with placebo instead of pembrolizumab, followed by surgery and followed by adjuvant placebo. Now, this trial was originally designed to look at the benefit of neoadjuvant pembrolizumab, but here we are talking about a special formulation of paclitaxel, where in most of the cases conventional paclitaxel was used, but the nanosomal paclitaxel was allowed in cases who had hypersensitivity reactions, or those who were having those who were having diabetes, where higher dose of steroids is used. In those cases, we can go with the nanoparticle paclitaxel. Next, please. So talking about the results, we have the updated efficacy data, which show that event-free survival and overall survival both were approved or improved with the use of this pembrolizumab, with a significant p-value in the neoadjuvant and adjuvant setting. But the point here to ponder upon is that we can even use the NAP paclitaxel instead of conventional paclitaxel in certain subset of patients where paclitaxel conventional cannot be used. So this is the idea of showing this trial particularly. And but talking about the particular results of this trial, neoadjuvant pembro plus chemo followed by adjuvant pembro resulted in statistically significant and clinically meaningful improvement in overall survival compared with neoadjuvant chemotherapy alone in patients with untreated high-risk early-stage TNBC. Next, please. And if you can see the NCCN guidelines also recommend the AC followed by paclitaxel, or in early cases even docetaxel plus cyclophosphamide based combination. And talking about TNBC cases, we can also use the preoperative pembrolizumab along with the paclitaxel plus carboplatin based combination, followed by AC pembro and followed by adjuvant pembrolizumab based combination as per NCCN guidelines also. And the taxane used here can be replaced by the nanosomal paclitaxel. Next, please. Next. So talking about this nanoparticle paclitaxel in the first line metastatic breast cancer. Previously, we spoke about the early stage, and now we are talking about the metastatic breast cancer. Talking about this Keynote 355 study where de novo TNBC patients were taken, or also those who were locally recurrent inoperable TNBC. The patients were divided into two arms where one arm received pembrolizumab along with chemotherapy. Now, the choice of chemotherapy here given was either paclitaxel or even nab-paclitaxel or gemcitabine along with a combination of carboplatin. And this was compared with only chemotherapy, the primary endpoint being PFS and OS. Next, please. Again, this study was done to show the benefit of pembrolizumab in certain subset of patients where the results were that in CPS more than 10, the overall survival was improved from 16 months to 23 months with the use of chemotherapy plus pembrolizumab, whereas this benefit was not seen in CPS 1 subgroup. And intention to treat population, again, this overall survival benefit of 2 months was seen by the addition of pembrolizumab, but this particular subset, that is CPS more than 10, derived this benefit of overall survival. But again, we are noting this particular point in this trial also, that the chemotherapy which was used in combination with carboplatin can either be paclitaxel or nab-paclitaxel without compromising the efficacy, but with a better side effect profile, where we can particularly use in diabetic patients or patients where we have to use higher doses of steroids to prevent the side effects. We can even use this nab-paclitaxel. Next, please.
Ma'am, we have constraint of the time, so maybe
Okay.
last 1 minute, please.
Yeah, just 1 minute. So again, if you look at the PDL1 CPS more than 10, we can use the albumin-based paclitaxel chemotherapy with carboplatin along with pembrolizumab in PDL1 subgroup of CPS more than 10 as per NCCN guidelines also. Next, please. Next. So talking again about non-small cell lung cancer. Next, please. Again, here this Keynote 407 study was taken where metastatic patients were taken. And again, when the carboplatin plus pembrolizumab was combined with either paclitaxel or nab-paclitaxel based combination, again, this trial was done to see the benefit of combining pembrolizumab. But again, the point here to note is that both paclitaxel and nab-paclitaxel in this patient subset was also allowed. Next, please. This again showed that the addition of pembrolizumab showed better benefit as compared to chemotherapy alone. But again, nab-paclitaxel can be used instead of paclitaxel in combination with carboplatin in metastatic NSCLC. Next, please. Pancreatic cancer. Next, please. Again, similar study design, but here adjuvant taxane was given when the patients of pancreas were operated upfront, and after that, in the adjuvant setting, gemcitabine alone was compared with a combination of gemcitabine plus nab-paclitaxel. Here, only nab-paclitaxel particularly was taken. Next, please. And these were the results. If you look at the overall survival improved from 36 months in gemcitabine alone to 40 months in nab-paclitaxel plus gemcitabine combination arm. Next, please. So this shows that gemcitabine plus nab-paclitaxel combination is better than gemcitabine alone. And this benefit was also seen in the Asian subgroup population as well. Next, please. So just to summarize, taxanes are commonly used chemotherapy for metastatic solid tumors, and this particular formulation, which is nano-paclitaxel, which is a novel formulation of paclitaxel, this can be used, and this can be used in option in cases of solid tumors, because this results in the improved efficacy outcomes with a manageable toxicity profile, and we even have a backup with the various trials which we have seen in TNBC, NSCLC, and pancreatic cancer. So this is a particularly effective option of nanoparticle paclitaxel, which can be used in all these solid tumors as well. So I once again thank Dr. Mukesh for giving me this opportunity. And
Thank you, Dr. Kanksha, for the detailed presentation. I just have one question. Is there any cancer where you still want to use the conventional paclitaxel and you don't want to use nano-paclitaxel after in this era?
So basically, talking about the data, we have this nanosomal paclitaxel usage in certain cancers only, talking about pancreatic NSCLC and the TNBC. These are the particular subsets where I only use nab-paclitaxel. But if you talk about ovarian cancer, I'm okay using the plain paclitaxel also, ovarian cancer. I use nanosomal paclitaxel or nab-paclitaxel only in patients where I cannot use conventional paclitaxel in cases of ovarian cancer. So only the approved indications I use nab-pacli. Otherwise, I'm okay with conventional also.
Thank you. Thank you. So for the next session, I will like to invite Dr. Prabhat Ganju, Assistant Professor, Medical Oncology, Homi Bhabha Cancer Hospital and Research Center, New Chandigarh. Dr. Prabhat will be talking on transforming the unresectable stage 3 non-small cell lung cancer landscape from Pacific to the LAURA studies. Welcome, Dr. Prabhat. Over to you.
Hi, good evening, Dr. Mukesh. Good evening, everyone. Can my slides be shared?
Yes, sir. We'll just share the slides. Yeah.
Yeah. So I'll just start. So I'll be talking about the stage 3 non-small cell lung cancer and how the treatment landscape has really changed with the advent of immunotherapy and target therapy, moving from the metastatic setting to the stage 3 unresectable setting also. Next slide. So, stage 3 lung cancers is a diverse group where you have stages from stage 3A, 3B, 3C. So, it can range from a small nodal disease with a higher stage of a T stage primary disease, or even bulky lymph nodal disease and a lower T stage, to all sorts of combinations. And based on this, we stratify them to stage 3A, 3B, and 3C. Usually 3Cs are not resectable. 3B, a certain population multi-station N2s will also be not resectable. And so in those patients, definitive chemoradiation is usually the treatment of choice. Now, there has been retrospective studies and audits where they've seen the survival of stage 3 patients, and it's less than 22% in stage 3A and less than 5% in stage 3B who received surgery as part of their treatment. So this is where chemoradiation has come in. Next slide. So as I was mentioning, it's a heterogeneous group, and our management really changes uh, uh, based on the T stage, the N stage, the location of the tumor, a lot of the other factors that are there. And all stage 3 lung cancers should go through an MDT. And this is really where you need a multidisciplinary management, because all three modalities of treatment are usually included. You need a radiologist on board, you need the pathologist on board, and even a molecular oncologist if possible. And the treatment is generally multimodality. Um, and if it goes to, if we look at the overall survival by the pathological stage, stage 3A with the median OS is somewhere around 41.9 months. But if you go to stage 3B and 3C, it drastically drops to 22 months and 11 months only. And the 5-year overall survival for stage 3C is somewhere around 12% only. Next slide. So, as I was mentioning, a lot of different factors go into deciding treatment of these patients, and you need to assess patient factors, where I mean, that could mean operability in terms of the medical fitness, pulmonary function, cardiac function, performance status, how the patients, I mean, if the patient is an active smoker, that is also a contraindication to doing a surgery. And certain tumor factors, the stage of the disease, the bulk of the N2 nodes, the number of stations involved, and so all these things make up our the eventual plan for treatment. Next slide. So this is where we have to define what is the stage 3 unresectable non-small cell lung cancer. Next slide. There is Asian consensus that biomarker testing should be done for unresectable non-small cell lung cancer. And here you have to decide whether the patient is fit for chemo radiotherapy. And in that case, we check for PDL1 and EGFR mutation as of now. I'm sure pretty slowly we'll have to test for the other mutations also. And based on this, then we have further treatment recommendations. Next slide. Yeah, next slide. Yeah, so definitive chemoradiation is the recommendation for unresectable stage 3. Next slide. Yeah, so completion rates for CTRT in real world is somewhere around 60 to 80%. Sequential is lower, 46% versus 63% for concurrent. And we really know now that concurrent is better than sequential, and sequential should probably only be used for patients who might not tolerate concurrent chemoradiation. Next slide. There have been multiple consolidation therapies that have been tried post CTRT, but none of them have really worked. They've tried chemotherapy, they've tried Jeftinib, consolidation with radiation also, but nothing has really improved survivals. Next slide. Yeah, next slide. So coming to the Pacific trial, next slide. Here they took stage 3 locally advanced and unresectable non-small cell lung cancers who did had not who have not progressed following definitive CTRT based with platinum based chemotherapy. Here, importantly, they have included both EGFR mutated as well as non-mutated patients. And here, patients were randomized to durvalumab consolidation at 10 milligram per kg every 2 weeks for up to 12 months. This was started within 6 weeks of completion of CTRT and randomized to compare with placebo. The co-primary endpoint was PFS and OS. Next slide. So overall survival at 5 years showed a difference, significant difference of as hazard ratio of 0.72, 47.5 months with durvalumab and 29.1 months with placebo. Next slide. Yeah, next slide. So if we see OS benefit was seen in all pre-specified subgroups except one, and I'll come back to that later. Next slide. Again, progression-free survival did show significant benefit with the use of durvalumab, 16.9 months versus 5.6 months. Next slide. Next slide. Yeah, and was seen across all pre-specified subgroups. Next slide. If we see incidence of pneumonitis in the trial, it was 33% with durvalumab and only 24.8% with placebo. So obviously, it is slightly higher with immunotherapy, as we do expect because of certain immune reactivation. Next slide. And pneumonitis, if we look at whether if you started the durvalumab consolidation within 2 weeks or after 2 weeks, it doesn't really make a difference on the survival. Next slide. And next slide. So PFS and OS, as I was mentioning, that EGFR subgroup, if we look at that, there was no survival benefit, either PFS or OS over placebo. And so in the EGFR mutated subgroup, we should not be recommending durvalumab consolidation. Next slide. So if we look at EGFR mutated non-small cell lung cancer in the unresectable setting, we then had the LAURA trial. Next slide. So here, patients again who were EGFR mutated non-small cell and did not progress after definitive CTRT. They were randomized to osimertinib 80 milligram versus placebo, and this was given till progression actually. The primary endpoint was PFS by BICR. Secondary endpoint was OS. Next slide. Baseline characteristics were matched between both the arms, whether it was stage 3B, 3C disease. Most of the patients received concurrent chemoradiation. The type of EGFR mutation was also more or less matched. Next slide. Yeah, next slide. So PFS showed a huge benefit with the use of osimertinib. And the median PFS was 39.1 months with osimertinib versus only 5.6 months with placebo. And the PFS hazard ratio was 0.16. Next slide. And as per investigator also, the PFS benefit was significant. Next slide. And was seen across all subgroups, the benefit with the use of osimertinib. Next slide. Next slide. Next slide, please. So tumor response was also much better with the use of osimertinib versus placebo, much deeper responses. Next slide. Next slide.
Yeah. So there's some issue with the internet, so it might take 1 or 2 seconds.
Sure, no problem. Yeah, the site of new lesions were very rarely brain with the use of osimertinib. So as we can see that CNS progression-free survival is much better with the use of osimertinib. Next slide. Next slide. So here, if you look at overall survival, the interim analysis did not show a overall survival benefit significant towards the use of osimertinib, and partly because of a lot of crossover, there was 81% of the patients who received osimertinib in the placebo arm also, and this is why probably there is no OS benefit as of now. Yeah, next slide. Median duration of exposure for the osimertinib group was somewhere around 23 months. So that's probably around 2 years. Whereas in the placebo group, it was around 8 months. And so generally the toxicities were also much more in the osimertinib group versus the placebo. But most of them were manageable. Grade 3 toxicity or worse was seen in 35% patients. Next slide. Yeah, again, here the toxicities that we mostly are aware of with osimertinib, those were seen. Next slide. Yeah, next. So, uh, yeah, next slide. So, the rationale for the indefinite dose of osimertinib here, which is the one thing that is really, which we all oncologists have a doubt about, is that in previous trials with TKIs that they've used, as soon as they stopped TKI therapy, the curves started to converge and the survival starts to worsen. So, and this is the same thing that they saw in the Odera trial also. A sharp drop in DFS curves after 36 months. So this is why this was the rationale for indefinite dose. Next slide. Yeah, next slide. So yeah, time to onset of radiation pneumonitis was also similar in both the arms. Next slide. So as per NCCN guidelines now for NSCLC stage 3 unresectable for both the EGFR mutated and the non-mutated subsets, we now have consolidation therapies. For EGFR mutated, we have osimertinib, which can be given adjuvant till progression, and for the EGFR non-mutated, we have durvalumab consolidation to be given for a year, and this has now become standard practice. Next slide. Yeah, and this is what we have mentioned that we have PFS benefits for osimertinib adjuvant use and OS and PFS benefits for durvalumab consolidation. Next slide. Yeah, next slide. Thank you.
Thank you, Dr. Prabhat, for the excellent presentation. Just wanted to ask you, what is the protocol at your center? Suppose a patient of clinically T3 and suspicious bilateral mediastinal lymph nodes on PET comes, and patient is a non-surgical candidate. Are you still going for lymph node biopsy, IBUS, bronchoscopy, or whatever, or you are straightly going for chemoradiation?
If the patient is going to be unresectable due to any of the reasons, then we do not go for mediastinal staging. We straight away go for chemoradiation.
The reason I asked is that some of the studies say for deciding the extent of the radiation field, maybe radiation oncologist can better answer. There should be a lymph node biopsy. We also not doing it. I just wanted to
Yeah.
know the
I don't know, maybe if there is some, larger trials where they've studied this, maybe we can change our protocols.
and how many patients you are able to start concurrent chemoradiation, considering you are working in a high volume center where getting radiation dates sometimes can be difficult.
So this is the actually challenge that we face, that especially in non-small cell. Small cell, we start them off on chemotherapy, but non-small cell is a big problem. Our waiting times are somewhere around 3 to 4 weeks also, and it becomes a problem. But
It
yeah,
becomes sequential,
we
more or less.
yeah no,
Okay.
we actually make it a point to give concurrent, even if
Okay.
it's late. We try to give it concurrent. Yeah.
Okay. Okay. Thank you. Thank you, Dr. Prabhat. For the next session, I will like to invite Dr. Chandrasekhar Prasad Singh, Senior Consultant Medical Oncology, SCG Abdul Razak Ansari Cancer Hospital, Ranchi. Dr. Chandrasekhar will be speaking on a very exciting topic, redefining PDL1 thresholds in metastatic TNBC, expanding the role of immunotherapy. Over to you, Dr. Chandrasekhar.
Hi, good evening, everyone. Thank you, Dr. Mukesh, for giving me this opportunity. So when we talk about metastatic TNBC, then PDL1 cutoff is a thing we look for whenever we offer immune checkpoint inhibitors to our patients. So as of now, we have data from two positive trials, Keynote 355 and Torchlight. So Keynote 355 had a PDL1 threshold of CPS more than 10, where you can offer pembrolizumab in combination with chemotherapy, be it nab-paclitaxel, gemcitabine. And Torchlight evaluated, toripalimab in combination with nab-paclitaxel, but the PDL1 cutoff was more than CPS more than 1. So, as we see in India, breast cancer is the commonest cancer, and around one third of these breast cancer patients have triple negative. I would say where I practice, it is more than that. Mostly young patients, and I would say more than 40% of our patients here are having triple negative breast cancer. So these are the historic landmark clinical trials of different immune checkpoint inhibitors for TNBC. In metastatic space, we have two positive trials, Keynote 355, where pembrolizumab was approved for PDL1 CPS more than 10. And we have data from Torchlight trial for toripalimab, where they use different scoring system for PDL1, not the standard one what we use in our clinical practice, DACO 22C3, but they use some different JS311 scoring system for PDL1 scoring, and they enrolled patients who had PDL1 CPS of more than 1. Majority of patients had PDL1 positive in this trial. And in early breast cancer, we have data from Keynote 522, where pembrolizumab is given in neoadjuvant setting with chemotherapy. So coming to the today's topic, Torchlight trial. This is a phase 3 randomized trial, multicentric, but mostly the patients were enrolled from China. And toripalimab was given in combination with nab-paclitaxel versus placebo plus nab-paclitaxel for patients having metastatic or recurrent triple negative breast cancer. Most of these patients were having first line treatment. I would say more than 95% of patients received first line treatment, and 5% received this combination as second line therapy in this clinical trial. So key eligibility criteria being histologically confirmed TNBC, patients should have stage 4 disease with less than one previous chemotherapy, but majority were treatment naive, and less than 5% only received second line treatment of this combination. Patients should have obviously good performance status, and they were randomized into 2:1 fashion to toripalimab with nab-paclitaxel versus placebo plus nab-paclitaxel. And stratification factors were PD-L1 expression, whether it is positive or negative. More than 57% of patients had PD-L1 CPS of more than 1, and whether patient had previous taxane or not, and whether they received first line or second line of systemic treatment. Primary endpoint being progression-free survival, uh, particularly in patients who had PD-L1 positive subgroup, as well as intention to treat population. Secondary endpoints being overall survival and other endpoints like overall response rate, duration of response, disease control rates. So if you see the patient demographics, then the majority of patients had PD-L1 positivity. More than 57% of patients had PD-L1 CPS of more than 1. Only 37% of patients had PD-L1 negative, that is CPS less than 1. And more than 94% of patients received this combination as first line treatment. Less than 5% received this as second line treatment. So if you see the progression-free survival curve, and as it was assessed by a blinded independent central review, if you see the median progression-free survival, then it is 8.4 months in combination arm, that is toripalimab in combination with chemotherapy, versus 6.9 months in placebo plus chemotherapy, hazard ratio being 0.77. That means there was 23% reduction in risk of progression or death with combination of toripalimab along with nab-paclitaxel. If you see the 2-year progression-free survival rate, then it is 20.5% versus 11.3% with placebo plus nab-paclitaxel. Now, if you see the subgroup analysis, that is patients having PD-L1 CPS of more than 1, if you see the progression-free survival, then it is not that encouraging. You will get a better idea when you will see the overall survival curve. Median PFS is 8.4 months versus 5.6 months, hazard ratio being 0.65. That means 35% reduction in risk of progression or death with addition of toripalimab over and above nab-paclitaxel. Now, if you see the subgroup analysis in this forest plot, you can see almost all the subgroups were benefited with combination, whether patient had PD-L1 CPS of 1 to 10 versus more than 10, whether patient had received taxane in previous line of treatment or not, and whether patient had de novo metastatic disease. So almost all subgroups were benefited with toripalimab over and above nab-paclitaxel. Now, this is the real picture of this trial. If you see the overall survival curve, then median overall survival in toripalimab plus chemotherapy arm, it is 33.1 months versus 23.5 months in placebo plus chemo, with stratified hazard ratio being 0.69 for all comers, that is intention to treat population. If you see the 3-year overall survival rate, nearly 48% of patients were surviving with combination of toripalimab plus chemotherapy, as compared to 32% in placebo plus chemotherapy. So there was 31% reduction in risk of death with addition of toripalimab to nab-paclitaxel as compared to placebo plus nab-paclitaxel. So OS data is better, and OS data is encouraging, and it looks better when it is compared to PFS data. So if you see the secondary endpoint, that is overall survival as assessed by a blinded independent central review in subgroup of patients who had PD-L1 CPS of more than 1. Median overall survival is 32.8 months in toripalimab plus chemotherapy versus 19.5 months in placebo plus chemotherapy. And 3-year overall survival rate is nearly 48% in toripalimab plus chemotherapy arm, as compared to 33% in placebo plus chemotherapy arm. So there was 38% reduction in risk of death with addition of toripalimab to nab-paclitaxel. Now, if you see the subgroup analysis of overall survival, then all the subgroups were benefited, whether patient had CPS of 1 to 10 or more than 10, whether patient had received nab-paclitaxel or taxane in previous line of therapy, and whether patient has received this treatment in first line setting or second line, and whether patient has metastatic disease or not. So all the subgroups were benefited with addition of toripalimab to chemotherapy as compared to placebo plus chemotherapy. Now, if you compare the OS data in those patients who had PD-L1 CPS of more than 10, although majority of these patients had positive PD-L1, but the number of patients who had PD-L1 CPS of more than 10 was 130 out of 500. And if you see the median overall survival, then it is not established versus 18.3 months with placebo plus nab-paclitaxel. And in patients who had PD-L1 CPS of 1 to 10, it is 32.8 months versus 19.5 months with placebo plus chemotherapy. So higher the PD-L1, I think you can see the hazard ratio is better for patients who had PD-L1 CPS of more than 10. So higher the PD-L1, they were benefited more as compared to PD-L1 of CPS 1 to 10. Now, another interesting thing is what about the response rates and duration of responses? So the duration of response is also increased with the addition of toripalimab over and above nab-paclitaxel. Objective response rates is nearly almost equal in both the arms, 66% versus 68%. But if you see the responses, these are durable with addition of toripalimab to chemotherapy. And a stratified hazard ratio for duration of response is 0.55. So you are getting almost similar response rates, but the responses are durable. And majority of these responses are partial responses, but they are more durable in toripalimab arm as compared to chemotherapy only. Now coming to safety profile, treatment-related discontinuation rates were very less. It is almost equal in both the arms, and treatment-related deaths were very few. Majority of the toxicities were of grade 2 and grade 1. Grade 3, grade 4 toxicities were less. Mostly immune-mediated toxicity were higher in toripalimab arm as compared to placebo plus chemotherapy. Rate of myelosuppression and other toxicities related to chemotherapy, they were almost similar in both the arms. So you can see the incidences of immune-mediated adverse events like thyroid dysfunction, elevation of liver enzymes, pneumonitis, cutaneous toxicities. These were higher in the toripalimab arm as compared to placebo plus chemotherapy. But these toxicities were mostly manageable, and they were of grade 1 and grade 2 in severity. So if you see the progression-free survival summary, then in those patients who had PD-L1 CPS score of more than 1, mind you, this PD-L1 CPS is based on different platform. It is JS311, which is used in China. In our clinical practice, most of the time we do DACO22C3 Ventana platform. So in those patients, median progression-free survival is 8.4 months versus 5.6 months. In intention to treat population, it is almost similar, 8.4 versus 6.9. If you see 1 year progression-free survival rate, then it is 41.1% versus 29.8%. And 2 year progression-free survival rate is 20.5% with toripalimab plus nab-paclitaxel versus 11.3%.
Dr. Chandrasekhar sir, a great presentation, but I think if you can conclude in next 1 or 2 minutes, please.
Just 1 minute there. Thank you. So 1 year progression-free survival rate, 2 year progression-free survival rate, everything is improved with addition of toripalimab with chemotherapy. Now coming to overall survival, median overall survival in patients having CPS of more than 1, 32.8 versus 19.5 months. 3 year overall survival rate is 48.4% versus 32.1%. So coming to my last slide, Torchlight trial established toripalimab with nab-paclitaxel as highly effective strategy, first line strategy, which delivers significant improvement in both progression-free survival and overall survival across the intention to treat population and PD-L1 positive subgroup. There is nearly 12-month improvement in median overall survival, 32.8 versus 19.5 months in those patients who had PD-L1 CPS of more than 1. And toripalimab with nab-paclitaxel achieved a 35% reduction in risk of progression that is median PFS of 8.4 versus 5.4 month. It underscores the depth and consistency of benefit in PDL1 positive subgroup. So with this, I would like to stop, and just to mention, in Keynote 355, we have patients who had PDL1 CPS of more than 10. In Torchlight, we have patients who had PDL1 CPS of more than 1. So, it broadens the indication, and probably it is more suitable for Indian patients where cost is an issue, and the majority of patients will have access to toripalimab. So with this, I would like to stop. Thank you all.
Thank you, Dr. Chandrasekhar, for the wonderful presentation. If you can, or if you want to share any of your experience of using toripalimab, especially in triple-negative breast cancer, whether in neoadjuvant setting or in metastatic setting.
Yes, so not in neoadjuvant. I have patients in metastatic setting on Zetorvi, and they are doing well. I would say response rates are good as compared to only chemotherapy. So hopefully, I need to see whether these responses are durable or not. But yes, initially we are getting better responses with addition of Zetorvi to chemotherapy.
Thank you, Dr. Chandrasekhar. For the next session, I will like to welcome Dr. Ketan Dang. Sir is Principal Consultant Medical Oncology and Hemato-Oncology, Max Super Specialty Hospital, Mohali. And Dr. Ketan will be speaking on therapeutic advances in HER2-positive breast cancer, current evidence and future directions. Over to you, Dr. Ketan.
Thank you, Dr. Mukesh, for this valuable opportunity. So today we'll be talking about a very, very important topic and ever-expanding space, that is HER2-positive breast cancers. This space has seen evolution of agents one after the other, which have improved the outcomes for our patients, be it the metastatic, neoadjuvant, or the adjuvant setting. So to start, first of all, I'll share my slides and then we'll proceed further. There's the system has hanged and the slides are not showing up. Can the organizers? No, they are the older slides.
Manya, Daud, anyone from the tech team can please share the slides?
Can I send these slides to Deepak? Can I share these slides with you so that you can immediately display them? Somehow they are not showing up on my screen.
Manya?
Yes, sir, you can share in the group, the faculty group, so that we can download and share it.
Second. Yeah. Unexpected glitch.
Not an issue.
Okay, sir. It's difficult to get hold of you and your presentation, I think.
As you have always been. Faculty group ONCOV. Here is it.
Yeah, they are showing up now.
So these are the slides.
So I have modified mine. So they are the ones that came up from me. Yeah. Okay, ji. So the therapeutic advances in HER2-positive breast cancer. Everything changed first with ETM1 and then, in fact, with pertuzumab, then TDM1 and TDXD. That turned things upside down and has made us spoiled for choices. And now the combination of TDXD and pertu, that has turned everything topsy-turvy. We had this in mind that Cleopatra is the standard for several years, but that has also been questioned, and this leads to real sequencing confusions. So starting with, next please. So this is the mechanism which we all are aware. So these are the various targets and how they function, we all know. And of note is TDXD, which has a bystander effect that no other drug has, apart from acting in even HER2 low settings, which is marvelous. It just needs the HER2 tag on the cell and then it's going to act. and send its payload inside the cell as well as on the bystander cells. So that is the beauty of TDXT. And other agents, yes, you can very well see that. So next, please. So coming to the pre-operative and the post-operative therapies first. Next, please. So neoadjuvant pertuzumab, we had great data on that. We know that addition of pertuzumab, that increases the PAT-CR rate. So that PAT-CR rate is considered to be an over a surrogate for survival. The shorter endpoint that is more convenient for the neoadjuvant studies. So pertuzumab was a very valuable addition to the TCH or the AC followed by T regimen that we used to use earlier. This all is very well known and well established. Next, please. So then there was study whether carboplatin is absolutely essential. So this NEO-CAR-HP and the Helen 006 studies, they have challenged this standard of care TCHP. And practically what we understand is carboplatin comes with a lot of hematologic as well as GI toxicity, and patients have other symptoms also, for example, electrolyte imbalance, altered taste, and so many other things, vomitings and all. So NEO-CAR HP study that showed that in selected group of patients, you can safely omit carboplatin. So to be practical, I would not omit carboplatin in high T stage or heavy nodal burden disease. But in the frailer patient and with low burden disease, omitting carboplatin is not a bad idea as shown by the NEO-CAR HP. It preserves the PAT-CR while reducing the toxicity, the hematologic and the GI toxicity of carboplatin. Next, please. So this is the NEO-CAR HP study, which is now allowing clinicians to omit carboplatin in the select set of patients without compromising on the PAT-CR. Next, please. So yeah, this is the no compromise PAT-CR data that we discussed, 65% almost. Next, please. So de-escalating neoadjuvant to weekly nab-paclitaxel versus the TCHP. Again, this is a positive study. So we can freely do this in the lower risk HER2 positive disease. That's the message in it. Next, please. So this is the PAT-CR data, not much of a compromise. We know that hormone receptor positive diseases as such chemos less sensitive, so it will have a lower PAT-CR data as shown on the right half of the slide. And in the HER2 hormone receptor negative space, the data is much better as expected. Next, please. So this is the fewer toxicities. They have here marked in red how much we gain in terms of toxicity and patient's quality of life. We're just switching to this regimen of Helen 006. Next, please. So this is the definition of high-risk breast cancer. So all the question is about escalating the anti-HER2 therapy. So this all started with the Cleopatra, where we noticed that in patients who did not achieve a PAT-CR, the IDFS and the ultimate survival was increased with the switch over from PER2 plus TRUST2 to TDM1. And thereafter, we have emerging data on TDXT. Next, please. So this is the Catherine data, which made headlines few years back, and we all shifted our practice in those patients who had residual disease. We changed from TRUST2 plus PER2 for total 1 year to TDM1. Although this came at the cost of thrombocytopenia, transaminitis, and somewhat neuropathy, but still the benefit was seen. The benefit was so convincing that TDM1 was the torchbearer for the next few years until we had this new kid come up on the block that was TDXT. Next, please. So this is the Catherine data, clear cut benefit, 13.7 IDFS benefit. But now the newer Destiny, I think 09 or 05. So Destiny data on TDHC is even much more better. That will change the future of where TDM1 stands at present in the residual disease setting. Next, please. So next, we'll move on from Catherine now. Yeah, next, please. So this all well aware that even whatever is the minimal disease, whether in the nodes or in the primary tumor, it is always beneficial to shift to TDM1. So this has been straight away challenged with DB05. So the head-on comparison of TDXD versus TDM1 in the operated setting where patients have already received neoadjuvant setting treatment and there is residual disease or there is high risk disease at presentation, which is defined by these key eligibility criteria. So now they have compared head-on TDXD versus TDM1. So the rationale for this had come from DB09, I think, the metastatic setting. In the metastatic setting, in the second line setting, initially they had compared TDM1 with TDXD. And TDXD outnumbered TDM1 in every parameter, whether it was overall response rate, progression-free survival, or overall survival. Although that did come at the cost of toxicity, and the major toxicity was ILD. ILD ranged from 10 to 15%, and it can be life-threatening. And we have to follow special guidelines for being suspicious and detecting ILD early, and then discontinuing even in grade 2 toxicity with TDXD. We have to discontinue if there is a grade 2 or beyond ILD. So that was the background from which TDXD had outnumbered and outscored TDM1 in every other aspect except for ILD. So then this neoadjuvant residual disease trial. Here also the results are promising and highly in favor of TDXD. The IDFS data has already come up. The survival is not yet mature, but it is highly expected that this will change our practice. And in fact, many clinicians have started to change their practice in patients with HER2 positive residual disease in favor of TDXD. Next, please. Yeah, so this is the data that I was talking about. Next, please. So we can see that the curves separating and favoring TDXD in the IDFS, which is out. Delta of 8.7% at 3 years, which is quite significant. Next, please. So this is the safety summary. Beware of the ILD for TDXD and beware of transaminitis, thrombocytopenia, neuropathy, etc. for TDM1, but still it is much more easily manageable than the ILD if it happens. So you have to have an early suspicion for ILD pneumonitis. Next, please. So now we came to the metastatic setting. So it was all about Cleopatra, very clear cut. THP, that is docetaxel, pertuzumab, and trastuzumab. Or in real life setting, we used to substitute docetaxel with either paclitaxel or weekly paclitaxel or nab-paclitaxel. So Cleopatra had shown a clear cut OS and PFS benefit with OS ranging up to 5 years, that is 57 months in the green box that we can see. So it's a huge OS when you use Cleopatra in the first line. So until now, Cleopatra has been our favorite until now, but now the disruptor TDXD plus PER2 data has come up, which has again confused the medical oncologist which agent to choose if it is affordable for the patient, which one to choose and how to sequencing. So this is a new confusion created by even better results of TDXD versus the plus PER2 over the Cleopatra data. So this is the standard Cleopatra data that we have. Next, please. So now DB09, if you combine PER2 plus TDXD, so what is the rationale? Why do you combine PER2 with TDXD? So we are blocking HER2 signaling, whether it is HER2, HER3, all sides by combining TDXD with PER2. And then you're sending the payload and also having the bystander effect. So this
Sir,
combination
sir
is
would request you to conclude your
okay.
presentation.
I'll go fast. Next, please.
Thank you.
So this data is especially marvelous. PFS data is out. Survival data is not yet mature, but it is likely to be a disruptor and change our practice. Next, please. So patina, when you have a Cleopatra-like regimen, if the patient is triple positive, in Cleopatra regimen, patient is triple positive. Once the chemo part is over, you start palbociclib. That further gives survival benefit, PFS benefit to the patient. We all have been doing it in triple positive, and now it is validated by the much awaited patina study. We already have been doing this in the patina. Next, please. So triple positive, maintain with patina, that is palbociclib, AI plus trastuzumab after the chemo part is complete. That gives PFS benefit that is shown here. Next, please. HER2 climb. So similar setting, but hormone receptor negative. So in that approach, Cleopatra-like regimen, THP or TH, and once the chemo part is over, then you maintain with tucatinib versus placebo. That also gives PFS benefit. So these are the new data that have come up, but the first line backbone here is Cleopatra-like regimen, THP or TH. Next, please. So this is the significant improvement with tucatinib maintenance rather than just continuing the anti-HER2 therapy. Next, please. So this benefit was irrespective of hormone status, but I'm sure in hormone positive disease, we will be using palbociclib or CDK4 inhibitor rather than tucatinib. Next, please. So tucatinib we know has especially good data with brain mets. Most robust data and CNS PFS benefit is with tucatinib is from the HER2 climb trial. That is TUCA TRUST2 CAPE in the patients with brain metastasis. That has the best data so far. So brain metastasis, whether active, you first treat them with local therapy. And if you want to choose the regimen, then tucatinib with capecitabine and tucatinib and TRUST2 is a great choice as per the HER2 climb. The other choice is TDXT. So CNS data is quite robust with TUCA. Next, please. So you can see the benefit of intracranial activity, a delta of 11 months. That's great. Next, please. So DB12. So that is again another data that is going to come up that is likely to be promising. In fact, TDXT has fared well in all of these, be it DB12 setting or be it even HER2 low or ultra low. Next, please. So this is the confusion and the spoiled for choices table. You all have so many choices, we as medical oncologists. So we have to sequence them in the right way. Next, please. So NCCN lists all these regimens, and these are the category 1 are also listed. Apart from these, we also have lapatinib, LAPCAP regimen, and the niratinib, that is oral TKI, that is very effective. Recently, we have data from LAPCAP versus CAPE and NIRA, and where NIRA has done very well. Next, please. In the metastatic setting. So thank you, organizers, and thank you, sponsors, for this facilitating this valuable webinar.
Thank you,
Back to
Thank you
Dr.
for the
Mukesh for his
presentation.
comments.
Thank you, sir. Thank you for the excellent presentation. Thank you.
Thank you.
So for the next session, I welcome Dr. Priyanshu Chaudhary, Senior Consultant Medical Oncology, Livasa Super Specialty Hospital, Mohali. Dr. Priyanshu will be speaking on the recent topics of breast cancer 2026 updates. Over to you, Dr. Priyanshu.
Thank you, Dr. Thank you, Dr. Mukesh. Can we have the slides, please? We have been allotted very little time, but the slides are, 60 numbers, so I'll be rushing through. Next. Yeah, so the first one is, the subgroup analysis of Natalie trial based on the gene expression and its prognostic and predictive impact. Next. So we all know that Natalie has shown significant IDFS benefit, that is ribociclib, for 3 years versus endocrine therapy alone. So next. So they use uh, BC360 platform for evaluating the intrinsic subtypes, and they use the same data for evaluating PAM50 based intrinsic subtypes also. So there was benefit in all the subgroups, luminal A, B, HER2 enriched and basal like, more in luminal B, HER2 enriched and basal like, but because the numbers were low, so the statistical significance was not achieved in those, but uh, there was no significant interaction between subtype and the treatment. So ribociclib benefited all these subtypes if they were okay according to the inclusion criteria. Next slide. Next slide, please. Yeah. So now this was Optima phase 3 randomized non-inferiority trial of test-directed chemotherapy in patient with high clinical risk, ER positive, HER2 negative, early breast cancer. So basically, what? Next slide. You can go to next slide. So what we have seen in Taylor X and RX Ponder. So next slide. So RX Ponder included N1 disease only. The Optima included N2 disease also. So up to 9 lymph nodes uh, were allowed, and the non-inferiority was achieved with endocrine therapy only if the risk of recurrence scores was less than 60. So the non-inferiority, the 5-year invasive breast cancer-free survival was 93.6% in endocrine therapy alone arm versus 94.8% in chemoendocrine arm. So non-inferiority limit was set at 3.5% absolute margin, which was not crossed. There was only a 1.2% difference in the uh, you know uh, invasive breast cancer free survival with endocrine alone. Next. Now coming to the safety profile and the distant recurrence patterns. Again, the distance recurrence free interval was 96% in the endocrine arm versus 97%. That is only 1% 5-year difference. Next. The methodological nuances and trial limitations. So, the current uh, trial the cutoff was, the analysis was a minimum 1 year follow up and up to two-thirds have 5 years follow up. And the cohort recruited a predominantly white population, and premenopausal women less than 40 years were excluded from the trial. And formal cost effectiveness analysis are currently ongoing. Next slide. So again, all the subgroups had non-inferiority obtained uh, in this trial. Next. So omitting chemotherapy in premenopausal patients, sorry, premenopausal women exhibit identical absolute non-inferiority margins to postmenopausal women, validating safe chemotherapy omission when treated with ovarian function suppressions. Next slide. Now, this was the lidera phase 3 trial with giredestrant as adjuvant, and giredestrant improved IDFS versus the standard of care endocrine therapy in high risk population, a hazard ratio of 0.70, 3-year IDFS of 92.4 versus 89.6. So there was a 31% reduction in metastatic disease risk. Next slide. So this we have discussed giredestrant 30 mg PO OD versus standard of care ET. So basically, this is a selective estrogen receptor down regulator and antagonist too. Next. So in stage 1 to 3 patients, adjuvant giredestrant showed an IDFS benefit over standard of care ET irrespective of menopausal status. A hazard ratio of 0.65 in premenopausal and 0.74 in postmenopausal. And the risk of developing metastatic disease was again lower. A hazard ratio 0.58 in premenopausal, 0.76 in postmenopausal. And safety was comparable between the menopausal subgroup. Next slide. Now coming to the switching of therapy. Dawood, can you remove that minimized window just above on the left upper corner? This the slideshow. No. There's a
Make it into
slideshow.
slideshow, Daud. Click slideshow.
No. Still it was showing. Yeah, now it's better. So next. Yeah. So Serena 6 first line camizestrant switch for emergent ESR mutations. So for the patients were evaluated for asymptomatic ctDNA increase with the emergence of ESR1 mutation and were either allowed to progress or switch to camizestrant. So there was a 7.6 months benefit with the interception. That is, median PFS was 16.8 versus 9.2 and a hazard ratio of 0.63. And a substantially more patient, 51% achieved clearance of ctDNA with the addition of camizestrant. Next slide. So this was again, there were two trials, Persevera BC and Avera BC. So in the Persevera BC, it was a phase 3 first line trial, upfront giredestrant plus palbo versus letro plus palbo. And in Avera, it was post CTK4/6 setting, giredestrant plus everolimus. This again significantly improved invasive PFS and both in ESR1 mutated as well as non-mutated tumors. Next slide. So first line giredestrant plus palbo resulted in a numerically improved PFS compared to the control arm, though it did not meet the predefined statistical significance. Giredestrant plus palbo was well tolerated with a manageable safety profile and no unexpected findings. And further exploration is needed to assess which patients may benefit from giredestrant in the first line setting. Next. Now this was again a Victoria 1 study with gedatolisib, which was again a PIK3 inhibitor, plus palbociclib plus fulvestrant. And the primary endpoint was PFS, and it had a 3-arm. So this is the study 2 data which is being presented. Next. So this is the problem. We all know there's a dual pathway with PIK3 and downstream pathways include PTEN, mTOR, or AKT. So if we inhibit simultaneously both pathways with PIK3 as well as CDK4/6. Next slide. So we have a better, efficacy. So GEDA plus fulvestrant plus palbociclib represents a potential new standard of care because of increased efficacy, 2 times median PFS, 11 versus 5.6. Objective tumor responses 49% versus 26%, and extended duration of response 15 to 24 months versus 7.4 months. Next slide. Next. So we all know these data of HER2 positive cancers, Destiny 11, 5, and 09 we have discussed earlier too. Next.
Sir, request you to kindly conclude your presentation.
Yeah, so we'll skip. I think we have already discussed these trial Destiny Breast 11, 9, and 5. You can skip that. Next. We also discussed HER2 Climb 05. Next. Go on, go on, go on. Dr. Ketan has just discussed these. Next. Move on to triple negative breast cancer straight away.
Next, 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 next.
This we have discussed. Go on.
Next, next, next.
Yeah.
Yes.
Next. So we all know that early stage TNBC, even with patients who achieve PATH-CR, the relapses are quite common, and 1/3 of residual disease patient experience an event within 5 years without PATH-CR. Next slide. Next. So because metastatic TNBC has a very poor survival, or 15% 5-year overall survival, and in India probably even lower, and 33% of early TNBC patients recover. Over 50% of patients never receive a second line of therapy due to rapid quality of life deterioration. Next. So the current landscape is in PDL1 positive. We have chemo plus pembro or pembro plus sacituzumab govitecan as another option we'll be discussing. In PDL1 negative, we have TROP2 ADCs, either sacituzumab govitecan or dato-DXd or systemic chemotherapy. And second line in HER2 low, we can give TDXT, and BRCA mutated, we can use PARP inhibitors. Next. So this is the keynote 355. We know pembro plus chemo versus chemo alone. So it is in PDL1 more than 10, it is a standard of care with both PFS and OS advantage. Next. Next. So we have these two trial, ASCENT-03, sacituzumab govitecan versus chemo, 9.7 months PFS versus 6.9, and the Tropion Breast 02 dato-DXd versus chemo, 10.8 months versus 5.6. These are already proven trials. Next slide. These are in PDL1 negative disease. Next. So the ASCENT-4, stay at this. The ASCENT-4 utilized a clinical synergy of ADC plus IO. So next slide. So sacituzumab govitecan plus pembro in PD-L1 positive metastatic TNBC had a median PFS advantage, and another important was that the long-term benefit beyond first progression was maintained with a median PFS 2 of 21 months. Next slide. Next. Next. Yeah, this was again the Tropion Breast 02 triple negative metastatic TNBCs where PDL1 was negative or low. Dato-DXT versus investigator choice of chemotherapy. Next. So again, Dato-DXT OS advantage of 5 months, 23.7 versus 18.7. And PFS advantage again of 5.3 months, 10.8 versus 5.6. Then another Isabran, another top inhibitors are being evaluated, which have shown impressive response compared to chemotherapy. Next. So PARP inhibitors is no longer strictly bound to germline BRCA. Somatic mutations and PAL-B2 also are actionable targets with PARP inhibitors. Next slide. This we have discussed. Destiny Breast 04. Next.
I would request you to conclude.
Yeah, so I think that is all I have. Thank you so much. And over to the
Thank,
organizers.
thank you, Dr. Priyanshu. You had a very
Thank you, Dr.
difficult
Mukesh.
task of discussing so many PPTs in such a short span, and you have done a wonderful job. If I
Thank
may
you.
ask, for which one of the molecule you are most excited about amongst these?
I think a combination strategy of Dato DXD plus uh, Pembro one, and two is the SERD and ESR1 inhibitors which we are getting. Maybe we have them at affordable cost in the future camizestrant, or this acituzumab govitecan is being launched, I think. So I think we, like, just like bladder, we have an ADC plus IO combination. And in TNBC, very, very difficult to treat young patients, metastatic disease. I think if we have more options in TNBC, that would be good.
Thank you, Dr. Priyanshu. From the breast cancer, now we will be moving to the lung cancer. And I welcome first speaker, Dr. Neha Gupta, consultant medical oncologist and hemato-oncologist at Max Super Specialty Hospital, Bathinda. Dr. Neha will be speaking on rewriting the ALK non-small cell lung cancer journey, the CROWN trial at 7. Over to you, Dr. Neha.
Hello, sir. Good evening, sir. And thank you so much, sir, for this wonderful opportunity. Are my slides visible?
No, not yet.
Are they visible now?
Yeah, they are visible.
Okay. Today we'll be discussing about the ALK positive NACLC. This is a sponsored session by Pfizer. We'll be discussing about first line therapy in ALK positive NACLC. What is the goal of discussing the first line ALK positive NACLC? Because we want PFS. As we all know that NACLC behave very bad. But yes, we have a mutation, targetable mutation with us, in which we have seen we have good PFS and overall survival rates. First-line PFS is a significant contributor to patient survival because of durable response and a deeper response. So, because we have seen that longer PFS will correlate with the longer overall survival. Secondly, why we want this is because the first-line treatment choice matters a lot. Because we have seen the patient who generally 1 in 3 patients do not receive the second-line treatment because of clinical deterioration from the rapid progression. And also treatment efficacy matters a lot in NSCLC because treatment efficacy decline with each additional line of therapy. And in the first line treatment, we want to protect against the debilitating impact of brain metastasis. As we know that in ALK positive NSCLC lung cancer, brain mets are very common. So with second generation TKIs, 20% of the patient develop brain mets within 4 to 5 years. And there's a threefold higher risk of death for patients who develop brain mets as compared to who do not develop brain mets. So we know that brain mets have a detrimental impact on patients' quality of life. So because of the lorlatinib, which is a third generation ALK TKI, which is designed against ALK resistant mutations and also delays their occurrence. So we know that lorlatinib effectively crosses the blood-brain barrier and retain at a very therapeutic levels. Because of which lorlatinib acts very good in metastatic NACLC with brain mets patients. Now we'll be discussing about the study design, that is a CROWN study. It's a phase 3 randomized trial. A comparison was between the lorlatinib versus crizotinib in locally advanced or metastatic NACLC lung cancer patients. Eligibility criteria was more than 18 years of age, histologically proven NACLC, ALK positive, no prior systemic treatment, good performance score, asymptomatic treated or untreated brain mets were permitted, and more than one or equal to one extracranial mets were included. It was randomized into lorla versus crizotinib, stratified according to the presence of brain mets and ethnicity. Our primary endpoint was PFS. Secondary endpoint was overall survival, overall response rate, OS, safety, and quality of life. So we can see in this that it was comparable. Arms were comparable. The median age was 61 years versus 56 years in crizotinib arm. And we can also see and then the presence of brain mets was 25% in the Lorla versus 27% in the crizotinib. And also 91% patient was stage 4 disease upfront in Lorla versus 95% in crizotinib. We'll be discussing about the 7-year analysis. We can see in the PFS in the IDT population at 7 years, it was wonderful for lorlatinib, in which median PFS was not reached. We can see beautifully in this graphs also, the curve separation was beautifully done between lorla and crizotinib. We can see clearly that at 7 years, 55% patients on lorla were alive and progression free. And more than 7 years of PFS is the longest PFS ever recorded in advanced lung cancer patient. Then we are looking for brain mets or without brain mets patients. In a patient without brain mets, in the Lorla arm, median PFS is not reached as compared to 10.8 months in crizotinib arm. In the graph also, we can see that at 7 years, 56% patients on lorlatinib were still alive and progression free. And then we can compare it with the with patient with brain mets. In that, median PFS was 86.3 months as compared to 6 months in crizotinib arm. That's a wonderful data because we all know that patients with brain mets behave very poorly, but because of the lorlatinib, now the PFS advantage is awesome. In this also, we can see that patients who were even free at 2 years had a 79% of probability of being alive and progression free at 7 years as compared to crizotinib arm. In this, we will see that time to intracranial progression in the intent to treat population, we can clearly see that at 7 years, 92% of the patients of lorlatinib treated patients remain free of intracranial progression as compared to crizotinib, and no new intracranial progression were noted after 30 months. Then we are looking for patient without brain mets, the time to intracranial progression in the lorlatinib arm. It was not reached as compared to 23.9 months in crizotinib arm. As compared to time to intracranial progression with the patient with brain mets at baseline, it is not reached in lorlatinib arm versus 7.2 months with crizotinib arm. We can clearly see in the graph also that 96% of the patient without brain mets remain free of intracranial progression at 7 years. And also patients with brain mets, 83% of the patients will remain free of intracranial progression at 7 years. Then come the cumulative incidence of progression brain mets as first event, which was lower in the lorlatinib as compared to crizotinib arm. We can clearly see in the group that 75% of the patients with crizotinib arm developed incidence of CNS progression as compared to only 7.9% patients in the lorlatinib arm. Similarly, the patient with baseline brain mets had incidence of CNS progression, which was seen in 92.3% patients with crizotinib arm as compared to only 10% of the patients in the lorlatinib arm. And patient without brain mets, the incidence of CNS progression was seen in 67.3% patients with crizotinib arm as compared to 4.7% patients with lorlatinib arm. So we can clearly see that with the lorlatinib arm, the progression with survival was very good and the patient is behaving very nicely without CNS progression at 7 years. So greater depth of response was associated with the longer PFS. What is depth of response? It is defined as best percentage shrinkage in tumor size compared with the baseline. We can clearly see from this graph, they have divided into 3 arms basically. Less than 50% tumor shrinkage, 50 to 75% tumor shrinkage, and more than 75% tumor shrinkage. More is the tumor shrinkage, more longer is the PFS. So we can clearly see that almost more than 50 achieving a response that is more than 50% can be an early indicator of high probability of remaining progression free at 5 years. We can clearly see in the 75% patients in the lorlatinib arm who has achieved tumor shrinkage of more than 75%. And that leading to more longer because of you will for longer period of time. Now we'll be discussing about the adverse events. How we can manage the adverse events. Dose reductions were used to manage adverse events in about 1/3 of patients. Recommended dose was reduction did not compromise the systemic events were partially or completely resolved with 1 or 2 dose reductions. Only 5 to 7% of patients have discontinued lorlatinib because of the adverse events. We can see in this particular arm that they have shown by decreasing the dose, would it affect the efficacy? We can clearly see that the patient with dose reduction or without dose reduction, the PFS was not reached. That means that by reducing the dose also, they are maintaining the intraclinic efficacy as well as the longer PFS survival. And now, what are the 7-year safety summary? Proactive management of adverse events, including dose modification, help the patient benefit from longer. Adverse events are well understood and most occurred within the 6 months of starting treatment. And only few % of the patient have discontinued permanently lorla because of adverse events. Lorlatinib safety profile was consistent with that of the primary analysis. No new safety signals were seen at 7 years. There was no increase in grade 3 or grade 4 events in the 7-year follow-up analysis. Only 5% of patients are discontinued lorla because of adverse events. And we can easily see that after 26 months, there was no new treatment discontinuation due to adverse events. This is the adverse events comparable between the lorla as well as the crizotinib. They were almost comparable between the two arms. We can see that grade 3 to 4 events were reported 77% of the patients in the lorla as compared to 57% in the crizotinib arm. And also we can see that temporary discontinuation was seen in 64% in the lorla as compared to 51% in the crizotinib arm. Only 12% of the patients were there who have permanently discontinued lorlatinib because of adverse events as compared to 11% in the crizotinib arm, which were both comparable. Then the most common adverse event which we see with the lorlatinib is the hypercholesterolemia, that is 73%, and hypertriglyceridemia to the tune of 71%. And a third most common was edema and peripheral neuropathy. We can see that patient complaining of weight gain, edema, peripheral neuropathy. These are the most common side effects which we used to face with the patient with the lorlatinib. Now they have shown that what are the most common side effects which occur in the lorlatinib. Like for example, in the first month only patient complain of hyperlipidemia, and second most common is edema. Patient complain of peripheral edema, and third most common is peripheral neuropathy and the weight gain. Other effects are also there, but they are not on the tune of it. It's not very common, like mood effects like low mood, irritability, period of altered reality, and also patient also face dysarthria or slowed speech, but it is seen in less percentage of patients. So basically, they have shown that likelihood of requiring discontinuation does not increase after 2 years of treatment. We can clearly see in the graph, after almost 2 years, only 5 to 6% patients have discontinued the treatment. After that, there was no new treatment discontinuation seen after 24 months. Now, how we'll manage the adverse effects? There's a 4-step approach. First, always counsel the patient and also the attendants about what to expect while taking lorlatinib. What are the adverse events patient can face while having lorlatinib? Then we should all test for lipid profile and for triglycerides at baseline and also at every follow-up visit. With the mitigation strategies first and with the clinical symptoms and with the baseline testing also, we can clearly see what a patient is suffering and what mitigation we have to take. Like we have to do, we hold the dose, we have to reduce the dose, or what we have to do. And a patient should visit at least monthly for all the potential adverse events. Any adverse events can be reported at that time. And then basically the lorla, the patient faces a hyperlipidemia. They have shown that we should get it tested at the baseline only. And we should choose any of the following. If there is mild hyperlipidemia, we can go for rosuvastatin 5 or 10 mg OD. If it is moderate intensity, we want moderate intensity therapy, then we should go for rosuvastatin 20 mg OD. Or we can also add the fibrates. Triglyceride remain more than 500. Despite the maximum statin doses, we should add fibrates or fish oils. So we can clearly see if the normal lipid levels are there. We should monitor lipid level at every follow-up. If we see any increase in the lipid level, like cholesterol more than 500 or triglyceride in the range of 150 to 1000, we should begin the lipid lowering strategy. Or if we see that total cholesterol level rising more than 500 and triglyceride more than 1000, then we should either add some therapy or we should change the lipid lowering therapy. And also we should withhold the tablet lorlatinib until the cholesterol level comes below 400 and triglyceride less than 500. And then we can restart the doses. If hyperlipidemia is uncontrolled because of any reason, we should withhold it, or we should reduce the dose so that patient can tolerate that therapy. Other cumbersome problems are like weight gain, edema, peripheral neuropathy. So they have shown what to guide. We have to guide the patient about the proactive lifestyle modifications. We have to guide if edema is there, patient can have limb elevation, patient can use compression stockings. And if patient is suffering badly, if patient is saying not tolerating, then we should, if it is getting worse, then we should stop the therapy, and then we should restart only when the symptoms resolve. But if it is stable or it is not that much, then we should continue with the same dose. And then we will summarize. We all know lorlatinib delivers the longest PFS ever reported in advanced lung cancer. 55% patients are still alive and progression-free at 7 years, which is a wonderful data, and with a good hazard ratio of 0.19. And Lorla is the only ELK TKI which prevent and control brain mets beyond 7 years. At 7 years, 92% of the patients in overall population are remain free of interclinical progression, which is a wonderful data. We have not seen this data in with any drug in brain mets basically. And proactive management of adverse effects, including dose modification, will help patient benefit from the Lorla. Patient can take Lorla for a longer time. And we have seen from the data that at 7 years, only 5% of the patient have discontinued Lorla because of the adverse events. So we all know that, yes, Lorla is the first line ALK inhibitor, which is prescribed in the metastatic as well as locally advanced NSCLC. Thank you. Thank you, sir.
Thank you, Dr. Neha, for the wonderful discussion. I think lorlatinib is definitely the drug which has significantly changed the prognosis for the ALK positive non-small cell lung cancer. Thank you. So now we move on to the hematology section. I welcome Dr. Brigadier Ajay Sharma, sir. Sir is Director and Head of Department Hematology and Bone Marrow Transplant at Paras Hospital, Panchkula. Thank you for accepting the invitation and joining, sir. Over to you, sir.
Good evening, everybody. Thanks, Dr. Mukesh. It's indeed a great pleasure to be part of the meeting this evening. It has been very great of you to continue the teaching program this way, and I'm sure all of us are getting benefited with this. So with that, let's start on the next section on the hematology topics. Can I have the details of the speakers, Dr. Mukesh?
Yes, sir. Sir, if you have the details, otherwise, if you
Yeah,
want, I can.
Yeah, kindly do that. I will.
Okay.
Yeah.
Sure, sir. Sir, to moderate the session, I welcome Dr. Sushant Mittal, sir. Sir is Director Medical Oncology and Hematology at Action Cancer Hospital, Delhi. Sir is my teacher and guide at Action Cancer Hospital also. Thank you so much, sir, for joining. Sir, can you call the panelist or should I go ahead?
Thank you, Mukesh. I'll just call the panelist. Dr. Jitendra Arora. Sir. Very good evening, sir. Good evening, sir. Dr. Akanksha Chhabda.
Hi, sir. Good evening.
Good evening, ma'am. Dr. Pooja Prasad.
Hello, good evening, everyone.
Dr. Ankur Mittal. Okay, Dr. Rajiv Saini. Dr. Kunal Jain. Okay. So last three panelists are not there. When they join, please let me know. Can I have my slides, please?
Sir, I think Dr. Ankur Mittal is there. His name is being shown. There may be some network issue. Dr. Ankur Mittal is there.
Okay, fine. Can I have my slides, please? Great. Thank you. So, we all come across lymphomas and we all like to treat DLBCLs because they have good prognosis, patient live longer, and we are satisfied, patients are satisfied, and relatives are satisfied. But nevertheless, we do face patients whose disease is refractory or they relapse. So how to go about changing the therapy in DLBCL, that would be the topic of discussion. Next slide, please. So Dr. Jitender, how often are you seeing, next slide, how often are you seeing lymphomas in your practice?
Sir, lymphoma present to me, DLBCL, Hodgkin lymphoma, and sometimes T cell lymphoma. But yes,
in last
around
6 months, we are in July,
yeah,
last 7 months, how many
yes,
DLBCL?
sir. Last 6 months, I have seen 5 to 6 patients, sir.
Dr. Akanksha, what about you?
I agree, sir. DLBCL is the most common, around similar patients, 7 to 8 patients I see, and followed by Hodgkin's lymphoma, followed by T cell lymphomas.
Dr. Pooja?
Yes, so we see a lot of lymphomas. Of that, DLBCL is the most commonest, around 10 cases, 10 new cases every month.
10 new cases every month?
Yeah.
So in last 7 months, you must have approximately seen 70 patients of DLBCLs.
Yeah, on an average, the new patients, we are getting at least between 8 to 10 every month. Yeah.
Oh, wonderful. Great. And Dr. Ankur? I think you have some network on. So Dr. Pooja, since you are treating the maximum number of patients, so I'll go about this. What are the clinical challenges you are facing in last 70 patients what you have treated? You must have done now interim PET scan. The patients who were treated in January, you must have done now the final PET scan also. So how many patients would have responded and how many have not responded or have relapsed?
Okay, so we are
Just a rough idea. I know it's difficult to calculate offhand.
But like, so we are treating patients with RCHOP as well as DAR-EPOC and now Pola RCHP also. So majority of patients, I would say 70% are high grade. They have high IPI, they have advanced disease, they have extranodal disease. Most of them have bulky disease. Age presentation has been quite varied. So we see from 20 till 80 years patients of like a variable age presentation. And because of that, so they will present with a poor PS in the beginning. They will require some pre-phase chemotherapy for bulk reduction. So we see around, so the responses that I'm seeing are nearly 60 to 70% will achieve some response, majority complete response and then partial response. But there'll be at least 15 to 20% who are primary refractory. And that is one major challenge that we are seeing.
Dr. Jitender, what about you?
Yes, sir. The challenge, sir, what I get is that if patient is present with the stage 4, especially with the bone marrow involvement, because most of present with the thrombocytopenia, anemia, and high dose or the according to the BSA dose is difficult to give in the beginning. So I start with the pre-phase. Then if patient is get better, then I add rituximab with mini R-CHOP. Then I escalate the dose. The patient get well. And in extra nodal lymph node also sometimes present with gastric cancer or colon lymphoma. They can develop a perforation or obstruction. So at that time, it is quite challenging for us to treat a DLBCL.
I think Dr. Ankur Mittal has joined. Good evening, sir. Are you able to hear me?
Sorry, yeah, sir. Sorry for the late, sir.
No, that's all right, sir. So how often you see DLBCLs in this year? We are running in July. So last 7 months, how many DLBCLs you must have seen, sir?
So generally, like in our hospital, we have around 4 to 5 lymphoma cases. They are visit to us, and about 2 to 3 patients they continue the treatment over here. So
2 to
on
5 per month.
Per month, yeah, 2 to 3, like we can say per month we are starting with the treatment. Either it is DLBCL or some other mental or marginal. And
I think Dr. Akanksha, it would be same for you.
Yes, sir, we have already said the challenges. I would just like to add one thing. So, the major challenge starts from the diagnosis itself. So, nowadays we are not saying it's a B cell lymphoma or T cell lymphoma. Within DLBCL also, there are a lot of challenges how to prognosticate the patient because every lymphoma is not the same. Now we have various like ABC type, GCB type, and many other types. So, the major challenge starts from the diagnosis itself, how to prognosticate the patient depending on various IPI, cell of origin, and all that.
So next slide, please. So since Dr. Akansha, you mentioned, since when did you start noticing in histopathology that this is ABC or GCB?
So I think, sir,
Before I'll make the question easier. Before the advent of poly-V, were you noticing whether it is GCB or ABC or cell of origin mattered, or now it matters?
sir, it used to matter before also, before the origin of poly also, but now yes, with the origin of poly and with the POLARIX trial, now we are much more confident in escalating the therapy or adding polatuzumab. But before that also, we were noticing for prognostication, we were noticing whether it is GCB type or ABC type.
So Dr. Jitender, since Madam was noticing, even if you noticed, did you have anything extra to offer to these category of patients, or you were continuing with our job?
Actually, sir, previously, so many trials are there. Like my mentor used to add the R2 CHOP link, means adding the lenalidomide. But the survival and OS was not benefit by adding any new thing. So if the patient can afford polatuzumab, I add that. Otherwise, R-EPOC or R-CHOP.
So do you counsel your patients for polar CHP?
Yes, sir. We counsel about the prognosis and adding that voice is getting. Hello.
Yes, yes, Dr. Jitender.
Yes, I counsel to the patient that this is your prognosis because you are having advanced stage. So this the new drug which is acting against this can help you. The main cost is the main hindrance is the cost to the patient.
Okay. So Dr. Pooja, since Dr. Jitender mentioned about cost, and you're saying that about 15 to 20% of patients are in your practice relapsing or are refractory. So what do you offer to those patients?
So when at baseline diagnosis, we are also looking at the, according to the Hans algorithm, GCB and non-GCB type, we are looking at double expressor, triple expressor, and double hit. So in patients who are triple expressor or double hit, for them, we are giving DAR epoch. We are not giving them RCHOP. And as far as polar CHP is concerned, then definitely we are counseling. Besides the fund issue, otherwise some patients are able to take.
Dr. Sushant Mittal, Dr. Kunal Jain also joined, and Dr. Rajiv has also joined. So all panelists are there, sir.
Okay, great. Thank you. So Dr. Pooja, since the patient has relapsed now, so what are you offering to them? Are you offering second-line chemotherapy, transplant, CAR T cell therapy? What do you offer them? Since you have treated them with R-CHOP or dose escalated R-EPOC, and even after that they have relapsed or not. And probably they must be, you would agree that in the slide what is shown, the unfavorable outcomes in R-CHOP are high IPS patients, non-GCB, double expressors, high grade.
This is the real world experience that, yes, they do not really respond very well with R-CHOP. So for primary refractory lymphomas, we are counseling them for CAR T or salvage chemotherapy followed by transplant. Both of these options are not really feasible for everyone, for cost issues, for logistics, everything. So we do require upfront better treatment options so that we do not reach to that stage.
So Dr. Kunal, good evening.
Good evening, Ji.
So what about your counseling to patients who are high risk or unfavorable DLBCLs? What has been shown in the slide? So what has been your clinical challenge? That are you treating them with R-CHOP? Are you escalating them? What do you do? Can I have the next slide, please?
Yeah, so the what is evidence currently with us supports use of polatuzumab in those high risk categories as has been
Next slide,
discussed
please.
just before. But the practical challenge is mainly the cost constraints. And once they are relapsed post first line, most of the patients, although we are looking at a curative kind of disease and scenario, but most of the patients will eventually become palliative because they are not eligible for high-end therapies, CAR T cell, or for transplant.
So since we are talking about economics and finances, but do you agree with the science that polatuzumab is giving a better PFS benefit, better chances that the relapse would be less? Can I have the next slide, please, organizers?
A short answer, I think, is yes. But if we are comparing, the problem here is that the problem here is we are used to kind of the magnitude of benefit that we saw post chop with our chop. We are not seeing that magnitude of benefit. So how much is acceptable in terms of magnitude of benefit, which will translate into clinical practice, is the question. This is the best option after our chop. So I think with cost becoming favorable, probably this will be more widely used.
Dr. Sood, do you agree completely with Kunal, or you would say that adding polatuzumab right now and then saving the money for CAR T cell therapy would be costing anything between 50 lakhs to 1 crore? Dr. Sood? Uh, uh, Dr. Ankur, can you take this question, please?
Sir, I generally, whenever the patient is diagnosed with DLBCL and we came to know that it is ABC type or double expressor or triple expressor, I generally counsel them for all the treatment options available, including polatuzumab, and we tell them the prognosis, like these are the percentage that the response rates could be better. These are the percentage that yes, there are differences in the response rates, and then let them decide. We talk to them regarding the cost, regarding the complications, and the chances of relapse. So in our clinical, yes, cost is one of the major issue. Most of the patients, they don't agree for polatuzumab because of the cost. Those who have insurances or reimbursements, they do go ahead with the polatuzumab, but many of the cash patients, they don't. Yes,
So
I totally agree
if
with
you
Dr.
have the CGHS patient or a panel patient and you have an ABC kind of histopathology, then you are convinced to use Polar CHP?
Yes, sir, we are, but the problem is now with CGHS and in panel patients also, these
The
drugs,
drug is not available.
are not available nowadays. Counseling them for pola tuzumab and the drug is not available, that unnecessarily delay the treatment sometimes. So we start with RCHOP, we tell them that yes, pola tuzumab is one option. We apply for it. If in case it is available, we can proceed. Otherwise, we'll continue with RCHOP in these patients.
So Dr. Akanksha, what has been your experience with polatuzumab? Next slide, please.
So, sir, I have used polatuzumab in few patients, and in whosoever I have used, the response has been good. So, I'll just share a case. So, there has been a patient who she had the ejection fraction of around 20% because of that extra nodal mass, which was actually compressing the cardiac and thyroid. So, we did that biopsy, came out to be poor prognostic factors. I used Pola RCHP, and she has achieved the complete response. Ejection fraction has again increased to 58% now, and she is doing absolutely fine. It's been almost 1 year now.
Okay. Dr. Pooja, your experience?
I think similar. I've also been able to use it in only few patients, and in those patients, it has shown good response.
Sir, I
Yes,
currently
Dr. Mittal.
there are two patients going on polatuzumab simultaneously. So both were affording class family, and we counsel them that these are the drugs available. Even though both of them were not high grade type of lymphoma. One is extramedullary, gut was involved. So the cost was not issue. They proceed with Pola RCHP. So that lady does very well. So she has completed the treatment. Just last cycle has been completed. Interval PET scan is DS is 1. The second lady, she's very fragile. She's around 62 years old and had some cardiac issue, uh, we decrease the dose of doxorubicin, we decrease the dose of cyclophosphamide, we start with Pola RCHP. They have the insurance of about 1 CR. Each and every cycle, the patient has issues. We are giving chemotherapy at 25% reduced dose, multiple admissions for neutropenia, multiple admissions for complicated UTI, and one time she has to land in the ICU. We have to delay the treatment for about 15 days. I think there are some patient genetic basis also which varies with the same protocol, same treatments, but yes, they behave differently.
So you think that is because of the polatuzumab, or it is just that the patient tolerance to the chemotherapy is very poor?
So most probably patient tolerance, because many times we have skin allergies also. We have shown to the dermatologist also. The dose has been reduced. The chemotherapy dose has been reduced, but Pola and Rituxi we have not reduced. Cyclophosphamide and doxorubicin dose we have reduced to 25%. And the interval PET scan is DS3. Still the nodes are there. We are waiting for the last PET scan.
So what I gather from panelists that it is an tolerable drug. It does not add to the toxicity, even if the ejection fraction is low. Even in elderly population, I have used in 82-year-old gentlemen, elderly population, I have used Polar CHP, and the results have been wonderful. I did not have any added toxicity, and the patient responded very well. Next slide, please. So now the question,
since you have, sorry to interrupt you.
Yes,
Just
Dr.
since you have probably better spectrum or wider experience in using this drug, so do you cap the drug dosage, or do you use as per the weight?
No, I use as per the weight, but definitely because of the finances also, we have to cap the dose at the nearest possible wherever the rounded off figure I can get, so that the vial is not wasted. That is fine. So now your opinion on prognostic significance. Dr. Kunal, do you agree that GCB behaves differently than ABC or non-GCB? Next slide, please.
There is enough now evidence and literature that outcomes with the pure GCB are good, but again, how we are identifying that is also a matter of concern. Like, we are using conventional histopath IHC, or are we going ahead, which we are not doing routinely for all the patients. If we talk about fish, yes, we are doing for most patients where there are indications, but other than that, more tests, no, we are not doing.
So if your pathologist just gives you DLBCL, do you push them to find the cell of origin? Can I have the next slide, please?
Yes, I think to the extent that the markers that they have, we have the complete panel, and I don't think now they are just stopping only at giving just high grade or just DLBCL. They usually give us some indication.
So I don't think they're able to change the slide. What the Polarix trial has told us that the chances of having next line of therapy or delaying the next line of therapy or reducing the next line of therapy has, with the addition of polatuzumab, is to the tune of 27%. So Dr. Pooja, since you were saying that 15 to 20% of our patients relapse or are refractory, so would you say that polatuzumab, if added to those patients, those 27% might benefit from this? Mr. Daud, can I have the next slide, please? Mrs. Ekta, Mukesh.
I mean,
Yes, sir.
I don't know whether this can actually be extrapolated, because see, we also have
Next, please.
case. I have two refractory DLB cells for whom we have given polatuzumab and they have not responded to that also. So
okay, so you gave Polar CHP and they were primary refractory.
No, not that. So I had one patient of Polar RCHP was primary refractory. I'm saying in those patients who received R-CHOP, they were primary refractory and planned for CAR-T and other salvage therapy. And so even after bridging with Polar, they're still refractory. So the disease biology is actually plays a very, very important role.
Important role. Yes, that's true.
So
I would
I'm
agree
not
that.
sure whether Polar can actually, outdo each and every aspect of the disease biology cannot be said. Like, yes, it does have more effect than R-CHOP, but not 100%.
So with this, the diagram shows that ABC the graphs are separating wide enough. You can almost put a hand in between the graphs. But for GCB, the graphs are overlapping each other. Although the indication is pan DLBCs, all kind of DLBCs. So are we counseling for GCB? That's a question. It's a learning curve. Everyone is trying to learn from that. But definitely in ABC, we want that patient should be benefited because of this wide separation. And since last 3 decades, as Dr. Jitendra was telling, that R2 CHOP has been used, or gemcitabine has been used, or etoposide has been used since many years. Many drugs have been tried in our CHOP regimen, but none of them had shown any benefit other what our CHOP has shown us. Next slide, please. This we have discussed. Next slide. So favorable outcome, yes, we have discussed. Next slide. Yes, extranodal site influence the treatment decision. Next slide. So Dr. Ankur.
Yes, sir.
So this testicular tumors or gastric lymphomas. So what has been your experience that how do you treat them? How do you counsel them?
In gastric lymphomas, we are very much worried about the perforation. We generally start with the pre-phase type of therapy and we counsel the family like maybe the urgent surgery may be required if in case the perforation happens before we start. And as the tumor burden gradually decreases, we add dietary modifications. Slowly we go ahead with the pre-phase and then the full dose of chemotherapy to be given. In testicular lymphomas, we counsel the family regarding the CNS relapse, and we generally add intrathecal chemotherapy with IT-MTX in the cycles of RCHOP with it. And in the first cycle, we get the CSF analysis also done. Most of them they are negative, but yes, we counsel them for the relapses. Uh, we have one patient which has liver involvement was also there to start with. Liver biopsy was positive, and in that also we added IT MTX with it. But with post treatment, she had that tuberculosis, CNS tuberculosis. Then that was managed, and then she had isolated CNS relapse. That was even though with IT MTX.
So extranodal disease, we would all agree that they are little tough to treat. As Dr. Jitendra was telling, he had one patient who had perforation and he had to reduce the doses and then take up for the surgery. Next slide, please. Next slide. Next slide. So in extranodal disease also, polatuzumab has shown that it is non-inferior to R-CHOP. Maybe it is better than R-CHOP. We can see that orange graphs are above the blue graphs of R-CHOP, and patients are benefiting in extranodal site as well. So Dr. Pooja, would you agree with this data which is shown right now? That extranodal disease, high risk, and polatuzumab should be offered to the patient?
Yeah, yes, we can offer.
They can offer. Dr. Kanksha?
I agree, sir. So basically, all the poor prognostic factors, PolarX has done subgroup analysis where they have shown that all the poor prognostic factors, they fare better when given Pola RCHP. So I agree to it.
So Dr. Jitendra, next time when you see a stomach lymphoma and you don't want perforation, would you like to add mini R-CHOP or mini RCH, Pola RCHP in that category of patient? Next slide, please.
It depends, sir. Yes, PolarX I would like to add, but along with the extranodal, it depends on the stage also. The bone marrow involvement also, third or fourth stage, along with the extranodal. That I will consider also.
So
For the
that is
aggressive.
what in this subgroup analysis, that majority of the patients benefited with addition of polatuzumab. The diamond is away from the unity, although the confidence interval is crossing the midline. But if we see that in majority the diamond is away from the unity, it is favoring polatuzumab. So yes, we might consider or we should add polatuzumab in this category of patient. Next slide, please. So Dr. Kunal, would you like to take this question, please?
Yes, sir. So high risk patients, obviously, if there are no barriers, I think currently POLA or CHP will be giving better responses and better tolerated as compared to some regime like our dose adjusted epoch.
How often, when was the last time you used dose adjusted epoch, sir? Our epoch?
Maybe about 6 months back. And patient after one cycle, stage 4, not affording for POLA. Although this also involves admission, costs are increased, but POLA definitely was out, and patient after one cycle declined that they will not get admitted and no center line, so shifted to R-CHOP.
R-CHOP. So I think dose adjusted R epoch is not an easy regimen to give. Lot of dedication, lot of dose calculation is required, and so if we are able to use it and sustain it as it is given in the trial, then it's a good regimen. But in Indian scenario, it becomes difficult to use, as Dr. Kunal was mentioning. Next slide, please. Yes, overall survival. So since we don't have an overall survival, Dr. Ankur, do you still feel that OS you would require to consult this patient, or PFS is good enough, or second line delayed in second line therapy is good enough data? Can I have the next slide?
The PFS is better to consult the patients, yes, but PFS is one which we are looking at.
Okay, Dr. Pooja, next slide. Would you want to wait for OS, or PFS is good enough for you?
Presently, all the data is showing that there is PFS benefit, but not much OS benefit. So more longer follow-up is needed to see whether this use of POLA RCHP is translating into improved OS.
Probably OS, it would be difficult to get because we have very good salvage regimens now. We have second line therapies, we have auto transplants, CAR T cell therapies, a lot of many drugs are available. So OS, yes, it will take some long time for results to mature. Next slide, please. So this is what I was telling, 23% fewer subsequent therapies treated with POLA RCHP versus R-CHOP, and economically also, because these 23% may not require CAR T cell therapy or auto transplant. So one should counsel the patient accordingly that if they are high risk, if the high PI score is high, if they are elderly, we must try and hit them hard in the first instance, all so that the subsequent therapy chances are reduced significantly, that to the tune of 23%, which is quite significant. Next slide, please. Overall survival we have discussed. Next. So Asian patients also benefited, and we in this trial we had few Asian patients and they had hazard ratio of 0.65, which is quite significant, and I think we are convinced with that data. Next slide. So this is a data from Dr. Reena Nair. Overall survival of best overall response rate at 90%, 2-year PFS is of 69%, 2-year OS of 80%, and across all the population, they were offered this therapy. Next slide. This was the data of R-CHOP. Next slide. So Polarix has been, when compared to Polarix, we found that the Polarix did little better. The PFS benefit, the 3-year PFS is better, 2-year PFS is better. Next slide. Yes. So, Dr. Kunal, have you used polatuzumab till now?
Yes, maybe a couple of 2 or 3 patients.
Did you find any added toxicity, or the tolerance was fine?
Not much, but I think the neutropenia risks are slightly more. So you definitely, we are anyway giving growth factor support with our job. So you need to give that anyway. But other than that, I don't, there have been no other
Added
added
toxicity.
toxicities.
I think Dr. Pooja and Dr. Akanksha also mentioned the same as Dr. Ankur also mentioned. So comparable safety profile, and lesser side effects or not no added toxicity. And in my experience also, even in elderly populations or fit patients or unfit patients also, they have tolerated very well. Next slide. We have discussed this, risk benefit is better. Next slide. Peripheral neuropathy is same. It is similar to RCHOP, maybe a little less. Next slide. So she is a 71-year-old lady, multiple comorbidities, double hit lymphomas, high IPI. Next slide. So Dr. Pooja, how would you like to treat? Next slide, please.
So again, this is a high risk, high IPI, double hit lymphoma. I think it was showing fish also positive for semen.
Yes, an elderly lady with multiple comorbidities.
So ideal treatment, if age was permitting, would have been DAR epoch, which can definitely not be given in this age. In fact, for her, if her PS is not good, then maybe just R mini chop. And if affordable, then polar RCHP with dose reduction in the first cycle and see how she tolerates with GCSF support.
Dr. Jitinder, next slide, please.
Sir, nowadays the guidelines recommended calibrate the geriatric score for the old age patient. We are also using for the chemo 70 score, what I remember. And then I plan according to that as per the comorbidities and the score. I will start with the mini or chop.
And would you like to add polatuzumab in this patient, or you would like continue to mini or chop?
If you don't have any previous peripheral neuropathy or some other condition, then I will definitely add.
Next slide, please. Yes, Dr. Ankur, can you take this question, please? Double hit lymphoma, young and fit patient versus unfit male patient.
In young and unfit patients, if the financial is not a constraint, then polar R-CHOP. If financial is constrained, we counsel them for DIPOC, but we give first cycle as R-CHOEP, if like the 0 dose of R-DIPOC, and how he tolerates, how much prolonged admission, prolonged neutropenia, we proceed for the next cycle. Preferably, if tolerable, R-DIPOC. And for frail patients, are either R-mini chop, if finances allows, polar chop, polar chop, RCH.
All panelists agree with that, or someone differs with that?
For young patient, DAR epoch, and fit elderly, DAR epoch, or the polar RCHP.
I think I'm running short of time. I have covered most of the points. Next slide, please. We have discussed. Next slide. Next. This we are not doing it, but we know it's a double hit lymphoma. Next slide. Next. Next one. We have discussed the elderly DLBCLs also. Next. GCSF prophylaxis required. So older patient rituximab. Yes, we have discussed. Next slide, please. Next. We have discussed that it's well tolerated. Next one. So I think we have covered most of the points. And next one, please. Next one. Great. So there is an trend towards overall survival, 36% reduction in disease progression and relapse, 23% reduction in second-line therapy. So I think we have covered most of the points. So I would like to thank my panelists, and thank you so much, and have a good evening. Back to the organizers. Thank you.
So, Dr. Sushant, a very good discussion. I must say that you have covered all the relevant points in the clinical practice that we come across day to day. It's not easy to actually discuss with the patient the management of DLBCL once you know all the prognostic factors, and especially if there are some high risk features. And I think almost all of us are now trying to get the cell of origin information Without that, I think it may be suboptimal to treat DLBCL today. So, as you have covered it, that we must actually tell the patient the possibilities of the relapse, because relapse is pretty common. Almost 50% patients are going to relapse. So, in that situation, the management is very dismal. So, this aspect needs to be discussed with the patient, because first treatment is the best treatment. And it's true that if a patient does not have the support, but if there is some kind of support available, then there is no problem. But in those patients where there is no financial support, this may be a very difficult choice. But still, I think educating the patient about this, because once the disease relapses, many a time patients do come with this thing. I only today had a patient who, in a relapse situation, today he is relenting, that if I had discussed it much more in detail, he would have thought about it. This feeling you all must be getting time and again. So I think detailed discussion at the first management time is very important, and you have tried to cover it also. So I think we have had very good informative panel discussion today. Thanks a lot, Dr. Sushant, and whole of your team. Thank you. And I thank Dr. Ankur to include this important topic in this meet. And I think this is a good discussion. Thanks, Dr. Ankur, and thanks, Dr. Sushant, and everybody in the panel. Thank you very much.
Thank you, sir. Thank you.
Thank you. Good evening.
Yes, Dr. Mukesh, can you?
Yeah. Thank you, sir. Can you continue to chair the next session? The next session is, sir, teclistamab in early relapsed refractory multiple myeloma, a game changer with transformative evidence. The speaker is Dr. Mukesh Chawla, Senior Consultant, Hemato-Oncologist and Bone Marrow Transplant Physician, Livasa Hospital, Mohali. Welcome, Dr. Mukesh.
Yeah, thank you, Dr. Mukesh Mansal, and good evening, all. Thank you for this opportunity. Without wasting, I'll just start my screen. We'll go ahead. Let me know, is my slide visible or no?
Yes, they are visible. Can we put it into the screen, our screen?
Yes. So good evening, all. So this is a sponsored session by Johnson & Johnson. So teclistamab, a game changer with transformative evidence. As we know that multiple myeloma remains incurable, so almost all patients will eventually progress. So they will either have a relapsed multiple myeloma, or they are unresponsive or progresses within 60 days. So in clinical practice, we keep both relapse and refractory disease as generally grouped together, because treatment approaches are going to be same. So most patients with relapsed refractory myeloma will relapse and require further treatment, and with each additional line of therapy leading to worse clinical outcomes, as you can see, with shorter time to progression with each subsequent line of therapy. And patients with triple class exposed relapsed refractory multiple myeloma who are receiving common standard of care therapies demonstrate a lower overall response rate and short median progression-free survival, and majority don't even achieve meaningful improvement in quality of life also. So this was locomotion and movement pooled analysis, where you can see the overall response rate was with standard of care was 32.5 and CR was hardly 0.7%. And PF based on responder status, whether VGPR or VGR, it was very less, as you can see from that. And evolving landscape in multiple myeloma. So the generally therapies which are available to us in clinical, they fall into two broad categories. So either they are like second or third generation of the previously existing drugs like IMiDs and PI second and third generation, or they are like novel agents like MABs are there, ADCs are there, bispecific antibodies and CAR-T therapies are there, and then other drugs are there which are in the pipeline. So new targets are being targeted for all these ADCs and MABs, as you can see. So these are FCR, H5, GP5, C5D is available to us. TACI, BCMA, lot of therapies are there. VGFR, CD38, and other in the pipeline are anti-CD138, DM1, and addition molecules like ICAM, VCAM, and lot other markers are there. So currently, teclistamab targets BCMA molecule on the plasma cells. As we can see from the germ cell B cells, they progress to memory cells and then form the plasma cells. And then progress to plasmablast to plasma cells, and then either they are short-lived or long-lived, and ultimately they become the myeloma cells in the plasma cells, which carry high percentage of BCMA. So BCMA is antigen expressed specifically on plasma cells and myeloma cells, and higher expression in myeloma cells than the normal plasma cells. And its key role in B cell maturation and differentiation, and it promotes myeloma cell growth, chemoresistance, and immunosuppression in the bone marrow microenvironment. So expression of BCMA increases as the disease progresses from MGUS to advanced myeloma. So teclistamab is the first-in-class off-the-shelf T-cell redirecting bispecific antibody designed to bind BCMA on the malignant plasma cells. It is readily available humanized IgG4 bispecific antibody that binds both T cells and CD3 expressed on T cells and BCMA on the multiple myeloma cells. So where they redirect CD3 cells to mediate the T cell activation as energization happen in the myeloma. So binding with this CD3 plus CD3 T cells mediates the T cell activation and cytokine induction and subsequent lysis of the BCMA expressing myeloma cells to secretion of perforating granzymes. And it is generated using DuoBody platform, which is a validated versatile system for high output bispecific antibody library generation and screening. So teclistamab is administered as a weight-based dosing, as we know, and it has a convenient subcutaneous dosing schedule, and it is given as a step-based dosing schedule to reduce the incidence of and severity of CRS. So it is given as step-up dose 1 on day 1 as 0.06 mg per kg, and then on day 3 as step-up dose 2, 0.3 mg per kg, and on the day 5 to 7, it is given as a 1.5 mg per kg. And then subsequently, once the patient is in remission, it can be changed from once weekly to 2 weekly if it is in patient is in CR for more than 6 months. So due to risk of CRS, patient should be instructed to remain within the proximity of a healthcare, as we know there is a high incidence of CRS, and be monitored for signs and symptoms daily for 48 after the administration of all doses with the step-up dosing schedule. So teclistamab, as we know, is indicated as a monotherapy for treatment of adult patients with relapsed refractory myeloma who have at least 3 prior lines therapies, including IMiD, PI, and anti-CD38 antibody, and have demonstrated disease progression on the last therapy. So outpatient administration is feasible, as we know that careful patient selection has to be done with close at-home monitoring. So we need to have an infrastructure preparation, and patient eligibility criteria is there to have a home daycare administration of this teclistamab. So experience administrating bispecific inpatient setting has to be there. There has to be access to the hematology department with familiarity to CRS, ICANS, and infection. Access to the emergency and ICU. Robust protocols to be in place so that all healthcare physicians should be aware of all the side effects. And on-duty onco hematologists ready to be contacted by the outpatients receiving bispecifics. And patient eligibility criteria, performance status should be good, no high tumor burden or rapidly progressive disease. Comorbidity should be well controlled, no active infection. Caregiver should be at the same home as and to monitor the adverse events, and patient should be living within 30 to 60 minutes to the hospital and can be considered caregiver should be considered reliable. No difference in eligibility criteria expected for those teclistamab or teclitamab, which is still not available. So treatment initiation, actions prior to step-up dose, we should be giving mandatory pre-medications, avoid simple education to the caregivers about the symptom of CRS and ICANS, with anticipated prescriptions like paracetamol and dexamethasone, and with this prescription for thermometer, blood pressure monitoring, and pulse oximeter for home monitoring. And post step-up dose management, adverse events monitoring should be there with the temperature, blood pressure, and oxygen saturation, and with the contact with the duty hemato-oncologist. And adverse event management, healthcare physician must follow a predefined infection management strategy as per the guidelines and follow the directions of on-duty hematologist. And whenever patient develop a fever, should take paracetamol and should be consulted for high grade more than 2 CRS. The anticipated prescription of dexamethasone should be taken following on the telephone and should report to the hospital within 30 minutes to 1 hour. So outpatient step-up dosing is feasible, safe, improve patient convenience and quality of life, and helps to relieve the hospital resources, and appropriate patient selection and counseling is the key. So teclistamab, as we know, so once a CRS happen, it can be restarted if there is an interruption in there. If it is less than 62 days interruption after step-up dose, then we should not repeat it. If it is 63 to 111 dose, restart at step-up dose 2. If more than 112 days have happened between interruption, then we should restart at the step-up dose 1. So dosing interruptions between 62 and 111 days have shown that the concentrations are lower than the step-up dose do, but similar to or higher than the step-up dose. So we can repeat the step-up dose, not the step-up 1 dose. And retrospective analysis of 61 patients of Majestic 1 who had treatment interruptions of more than 28 days found that only 2 patients had CRS when restarting teclistamab, around 3.3%. So it is the first in class off-shelf T-cell redirecting bispecific antibody against the BCMA on malignant plasma cells. Personalized base-pair dosing and convenient subcutaneous dosing is there, which can offer the flexibility of outpatient administration and potential for alternative dosing. It can be restarted after prolonged treatment interruption, more than 62 days. No need to repeat the step-up dosing. In patients who have more than CR for minimum of 2 months, a reduced dosing of subcutaneous 2 weekly may be considered, and less frequent dosing is still not approved but under evaluation of 3 mg per kg every 4 weekly. So this is Majestic 1 efficacy. Treatment with teclistamab demonstrated deep responses with overall response rate of 63%, CR of 46.1%, and VGPR of 59.4% in triple class exposed lab refractory multiple myeloma with a median of follow-up of 2.5 years. At a median follow-up of 2.5 years, a median progression-free survival and median overall survival were not reached in patients who achieved more than CR. So as you can say, the duration of responses, the overall was median duration of response was 24 months. With CR in not achieved and more than VGPR, it was 25.6 months, and median progression-free survival overall it was 11.4 months. More than CR it was not achieved, not reached, and more than VGPR it was 26.7 months. And it demonstrated deep and durable responses in the 3 clinical trial cohorts when it was pulled from the Majestic 1 Chinese cohort and Japanese studies. The overall response rate was little higher, 66.4% with CR of 49.8%, VGPR more than it was 63.6%, which included almost 217 patients. So patient encompassed a wide range of weight categories and racial backgrounds with a median follow-up of 29.2 months. So this was post-hoc analysis of the Majestic 1 showed that median PFS, median overall survival, and median DOR were prolonged compared with the overall Majestic 1 analysis when patients who died from COVID-19 were censored. So once we did a censored for COVID-19, the median progression-free survival, as you can see, it was 15.1 against 11.3 months. Median overall survival was 28.3 against 21.9 months. And median duration of response was 26.7 as compared to 21.6. So when censored for COVID-19, the results were actually better. So patient reported sustained and clinically meaningful clinical improvement in quality of life also. And patients who have CR or more generally improved better quality of life than those with VGPR and PR, as we can see, depending upon the various scales, even quality of life and the pain scales also. So treatment with the Majestic 1 teclistamab demonstrated an overall response of 63%, CR of 46.1%, and median follow-up was 2.5 years with the triple class exposed relapsed refractory multiple myeloma. And patients were then transitioned to subcutaneous fortnightly once the CR was achieved at 6 months. And median progression-free and overall survival not reached in patients who achieved CR or more responses. And in combined cohort of 217 patients, there were overall response and median duration of response was better than the Majestic 1 trial. A post-hoc analysis of the Majestic 1 showed that the median PFS and median overall survival and duration of response were prolonged compared with the overall Majestic 1 analysis, even when the censoring was done for the patients who died from COVID-19. And even this we have discussed that the quality of life are also better in patients who achieve more than CR. So this was again just a brief about locomotion study highlighted that the patients were 2.3 times were more likely to reach overall response rate with teclistamab versus the standard of care therapy they are real world therapy with a significant p-value, as you can see, with the significant improvement in PFS and duration of responses. So this was pooled analysis of locomotion and moment studies demonstrated that the median PFS, median OS, and duration response were nearly 3 times, 2 times, and 3 times longer respectively with teclistamab versus the VRL treatment choices in patients who were triple class exposed relapsed refractory multiple myeloma. So teclistamab demonstrated a substantial efficacy benefit against the current off-the-shelf therapies for patients with relapsed refractory multiple myeloma, as we have seen with locomotion studies and moment studies. And pooled analysis have demonstrated better median PFS and overall survival and duration of responses, which were almost 3 times, 2 times, and 3 times longer with the teclistamab than the current therapies. So in patients, there was subgroup analysis was then patients with high risk features, those including, as we can see, the overall response rate was 63. With the high risk penta refractory, it was 60%, as we can see. And then high risk cytogenetics, overall response rate was 60.5. And patients who had age more than 75 years, the response rate was 54.2. And then with plasma cells more than 60%, it was 44.4%, as we can see. And in the higher stages also, the responses were better than the current standard of care. In heavily pre-treated patients, even exposure to prior BCMA target therapies, we can see the overall response rate was 52.5. And prior CAR-T therapy, it was, you can see, the responses were quite equivalent in the patients who have received prior CAR-T therapies also. And it was generally consistent with the then the patients who do not have exposure to the BCMA targeted therapies, the results were almost similar, with median progression-free survival of 4.5 months and median overall survival of 15.5 months. And responses occurred early, deepened over time, and were durable, even in the patients who were exposed to the prior BCMA or received a CAR T cell therapy. And efficacy was increased in patients who received teclistamab in earlier lines of therapy, that is less than or equal to 3, as compared to who have received more than, in later lines of range, more than 3 prior lines therapy, supporting the use of teclistamab early in the treatment pool. As we can see, the earlier use, the median PF was 21.7 against the 9.7, and median DOR was 24 months. So it has highlighted that patient with high-risk features like penta-drug refractory, high-risk cytogenetics, more age, response rates were comparable, those with the overall population. And patients heavily pre-treated with prior BCMA therapies, teclistamab showed a promising responses and early and deep responses over time and were durable. And efficacy was increased if used in earlier lines of treatment as compared to the later lines, supporting the earlier use of teclistamab in patients who are relapsed refractory. So with median follow-up of 2.5 years remained well, teclistamab remained well tolerated, and rate of discontinuation due to adverse events remained low. So mostly adverse events were hematological, and rest we know that CRS, infections, and ICANS were the common ones. Teclistamab continued to demonstrate a manageable safety profile with new safety signals observed. CRS, cytopenias, and infections remain the most common adverse events, as we know. And adverse events leading to dose reduction or discontinuation were very less, actually. CRS events will go through quickly through this. CRS were very commonly with the use of, as we can see, they were predictable, manageable, and generally mild in severity, around 72%. But with the use of prophylactic tocilizumab led to 65 relative reduction. So almost 25% with the prophylactic use of the tocilizumab, as we can see. And CRS was from any grade 72%, a grade 3-4 were hardly 0.6%. And there were almost from 72 to 25%, it was like almost a reduction of 65%. So there were no changes in CRS at 2.5 years of median follow-up and predominantly of low grade, as we can see. So this was OPTIC study, prophylactic tocilizumab prior to the step-up dose, mitigate the risk of CRS in outpatient. Almost 100% of the patients had this reduction in the severe CRS, as we can see. Only one patient experienced CRS grade 1, which were managed with dexamethasone, and no cases of ICANS were reported. One patient required hospitalization due to treatment-related delirium with febrile neutropenia. So prophylactic tocilizumab prior to step-up dosing mitigate the risk of CRS and increase outpatient accessibility at community centers. So CRS monitoring and investigations. So we should be doing a detailed, taking a history and rule out from the infections and other disorders. And mitigation, step-up dosing and pre-medication may reduce the incidence and severity of CRS. So coming to manage according to the grading, grade 1, 2, 3, and 4, we should be taking. So grade 1, mostly symptomatic, may consider early tocilizumab. Grade 2, use of tocilizumab 8 mg per kg, and may add supportive like oxygen supplementation and fluids. And low threshold for steroids. Grade 3, dexamethasone 10 mg every 6 hourly with tocilizumab. Might consider shifting to ICU. Grade 4, shift immediately to ICU, high dose pulse steroid with tocilizumab and salvage treatment, even including anakinra. So, coming to ICANS, the overall incidence of neurotoxic events was low, most being predominantly of low grade and fully resolved with treatment discontinuation, as you can see. So, hardly ICANS percentage was 3%, and no change in rate of ICANS at 2.5 years of median follow-up. So again, monitoring, investigation, and managing depending upon the grade. For grade more than 2, we should be performing a detailed analysis and rule out other potential causes like toxic, metabolic, and infectious. Look for clinical or subclinical seizures. We should be doing EEG and CT MRI in the grade 2. If it is more, then we should be going for a CSF analysis also, and a low threshold for ICANS to treat with the steroids. And focus.
So sorry for the interruption. Kindly conclude in next 2 minutes.
Yeah. So infections, we know that we need to go for a prophylaxis. We should be looking for CMV, viral markers, and even for PJP also. Management and prophylaxis, we know that we should be doing that. Hematological, we should be knowing just a brief about that. That IG replacement should be done for all the patients, preferable to maintain more than 400 milligram per deciliter, as we know that. So we know that teclistamab demonstrated a predictable and manageable safety profile in patients with low rate of discontinuations. This we have already discussed. Hematological, we know that how to manage that. Just one slide about that real world data is also really tech, which is shown that the teclistamab out of clinical trials conducted in Europe and Israel again has shown that overall response rate of 60.2%. Just coming to the last few slides. So these are the studies from outpatient administration from USA and the Europe. So coming to real world evidence, growing real world evidence for the effectiveness, safety, and feasibility of teclistamab in patients with triple class relapse refractory myeloma. So studies across the US and Europe have shown deep responses with overall response rate more than 55 to 60%. Clinical trial populations are often not representative of the real world population, who typically have more comorbidities and consider less fit. Real world has shown that these are even safe in the unfit patients also. They have shown similar overall response rate and lower rates of infections and CRS as compared with the trial, and demonstrated real world efficacy in elderly and frail patients also, with the median PFS of 16.4 months in French patients, even in elderly patients. Teclistamab is feasible in patients with renal impairment with efficacy and safety comparable to patients with normal renal function, and outpatient administration is feasible with careful patient selection and close home monitoring. So coming to the last slide summary, that overall response rate of Majestic 1 has shown of 63% with CR 46.1%, median follow-up of 2.5 years. Deep and durable responses can be transitioned to fortnightly subcutaneous dosing, and demonstrated a predictable and manageable safety profile with a low rate of discontinuation, and can be done in a daycare basis also with selected patient profile. And real world data with realistic studies has shown that the patients safety of and responses are comparable in the real world also. Until now, more than 15,900 patients have been treated with teclistamab. So that's all. Thank you so much.
Thanks, Dr. Mukesh. Actually, there are a lot of information to be covered in this short time. It's not possible. So I think you have tried to cover most of the points. The many things will still remain. There are many queries also will remain. Just to add to your whatever you have told, is one needs to remember that because after daratumab, now we know that there is a need for further therapies, and patient would need, as you mentioned, one day or the other. So we need to sequence them optimally, because CAR T cell therapy is also available to some extent, and it is going to become more and more available. So the sequencing will be important. I think you could not cover that because of the short pause to the time. that one needs to remember that if patient has to be given CAR T cell therapy, it's better to give CAR T cell therapy before teclistamab because of the fact that there could be T cell exhaustion after giving teclistamab, and after CAR T we can have a long remission rate time, so that the teclistamab will be useful at that stage. And second thing is that we need to remember that almost 30% or so there may be a failure to teclistamab responses because of the resistance. So we should choose these agents very judiciously and carefully and sequence them properly, because CAR T cell is around, and then we need to explain to the patient. But the problem with the CAR T is the availability, and that the time to after the harvest is done, and all those issues where the teclistamab is available across the in the shelf. So there will be temptation to use teclistamab straightway, but one needs to remember that after teclistamab there could be problem if patient has to go in for CAR T. So that needs to be discussed also. And I think otherwise you have covered all the aspects. If there are any questions, I will like to invite from the audience.
Sir, if I can use this opportunity, any
Yes.
experience of using teclistamab, sir? You can guide us, because I have actually not used till now.
So actually teclistamab is not much used. I have an opportunity to use in 2 patients, and suddenly, because CAR T cell therapy for myeloma was not available until recently, and it is still not available for clinical use. So that was the only option available to us. So actually the main problem is usage in the initial dosage calculation. That's the main problem, because the vials, you need to you end up wasting the drug. But I think after that, because the subsequent dosages is not that difficult, you can give a full vial, and after the initial 2 doses. But the initial 2 doses is a problem, and then otherwise CRS is actually not much of a problem. If you are careful, you can predict it in time, and you can handle it. So I think, and it can be, you need to admit the patient. That's the most important thing. It's better to do that. And the the responses are good. At least initial responses are good, but the long-term responses continue to be a problem, especially in the heavily treated patients. So again, sequencing the therapy in the right time before patient has exhausted all the T cells, it's better to use it much early than waiting it for long. And then, you need to remember that daratumab, the patient is already on daratumab, so you need to sequence that also.
Thank you, sir.
The
Thank you.
commercially available CAR T becomes, then we'll have a lot of things on the table.
Yes.
Then it will become a more that how we sequence that.
Yes. So
Till
once
we
CAR
talk
T is
about
available,
bytes are only available with us right now.
that's true. That's the problem, that CAR T is not yet available for clinical use. So once that is available, and again the cost is going to be another issue there. Even though even in teclistamab the cost is going to be there, but then there is the cost which is much more than the transplant at the moment. Unfortunately, because of the exclusiveness of these companies who supply car. So that's the problem. So these issues are going to be a problem in management, because patient has already used daratumab and has spent a lot of money, and even if it is insurance supported patient, it's not easy. So that problem remains. And but certainly, if these are available, if it is possible to use, then certainly myeloma actually can reach a stage where we can call it a curable disease, and that's most positive thing about it.
Thank you, Dr. Mukesh Chawla, for the wonderful discussion, and thank you so much, Ajay sir, for so elegantly and eloquently chairing the sessions. Thank you, sir. Thank you so much. Now, from hematology, we move on to a very interesting topic, basically the backbone of all oncology. We move on to the pathology. I welcome Dr. Rajiv Tangri, sir. Sir is technical director histopathology and cytopathology, Dr. Lal Path Labs, National Head, Delhi. Sir will be speaking on emerging role of artificial intelligence in oncopathology. Welcome, sir. Over to you.
Thank you, Dr. Mukesh Bansal, and thank you very much for giving me this opportunity. I would share my screen now. Is my screen visible?
Yes, sir, it is visible now.
Okay, thank you. So I'll just... Yeah, thank you once again, and thanks for this opportunity to present the topic at this reputed forum. So my topic today is emerging role of AI in oncopathology. It's a huge topic, but I'll try to concise it within 15 minutes allotted to me. So as we know, AI is present everywhere now and is significantly present in our life. I mean, we see AI in multiple spheres of our life, including Alexa, or even the traffic lights that we encounter every day, the auto-driven cars, drones, the smart watches. So everything is controlled by AI. Even the Google Maps that we use day in, day out is driven by artificial intelligence, and it helps us in deciding the best route to our office or back to home every day. In healthcare also, AI has infiltrated very significantly with the AI-assisted robotic surgeries now available, the virtual nursing assistants, AI-assisted medical diagnosis. In radiology, AI is very significantly present now, medical image analysis, drug discovery. So all these are the various areas where AI has been present since at least a few years now. We also know that there are a lot of downsides of AI, the biggest one being invasion of our privacy, AI biased, loss of human jobs, which is a possibility, to, very severe downsides, including the AI terrorism. So let's not talk about the downsides now. Coming back to our own topic, how AI has changed pathology and especially oncopathology. Now, AI in pathology is said to be the third revolution in pathology. The first one was immunohistochemistry, and then came molecular pathology, and now artificial intelligence in histopathology or in pathology. Though we see that the word artificial intelligence, machine learning, computerized image analysis, all these were used in early 2000s, also in 1956, 1965, and so on. But the actual revolution or actual change came up in 2017 when Philips was the company who received approval for a digital pathology whole slide scanning solution. And that was the beginning, or you can say the beginning of the revolution into artificial intelligence, because digital pathology is the basis of artificial intelligence. Now, why do we need AI or digital pathology? We are already reporting pathology for centuries now, and so why suddenly now we need digital pathology and AI? So this is a word map, and published by Dr. Andre Bishop in the Pathologist Journal, and it shows that the number of pathologists is very small. I mean, the population of pathologists is very small compared to the whole population, and you can see that most of the areas in the world, except for America, Canada, and maybe Iran, they are in red or orange. India falls into 10 to 19 pathologists per million population. And by an estimate by 2030, the number of active pathologists may further drop by 25 to 30%. Now, this is combined with the increasing pressures to move faster. I mean, we are pressurized to give out faster reports, the reports which are more integrated. I mean, not only the pathology reports, but I mean, now because of the molecular evolution, all the diseases, especially the cancers, various type of malignancies, they have associated molecular signatures. So, I mean, there is a requirement that we provide all those integrations, everything in the report, but more efficiently. And now, since the number of pathologists are reducing, there is definitely increased pressure. So probably AI holds the answer to this need and maybe much more. How can AI help us in pathology, and how does it do it in pathology? I mean, it can help us in tumor detection quickly. It can help us in tumor classification. It can help us in tumor grading. It can help us in cell segregation and quantitation. Wherever cell counting is required, AI gives us very quick answers. In identification of lymph node metastasis, in detection of mitosis, in detection of perineural invasions. These are some of the used cases that that are available to us in clinical practice. And I will show you how we are using it in our clinical practice at Dr. Lal Path Labs. So at Dr. Lal Path Labs, we were actually had the first mover advantage. We were the first commercial laboratory or private laboratory in the country to acquire the digital pathology platform or a scanner in 2018. And the journey has been upward since then. Today, we are sitting in July 2026, and more than 70 doctors in our team, they are trained on digital pathology. We have reported more than 1 lakh cases on digital pathology. We have reported more than 15,000 cases of breast cancer using AI-assisted pathology, the ERPR HER2 and Ki67, and we have reported more than 3,500 cases of prostate using AI tools. Now, what is the requirement of artificial intelligence in reporting of prostate cancer? As we all know, according to the CAP and ASCO guidelines, there is a requirement to report Gleason grading, Gleason patterns, grade grouping, tumor quantitation, perineural invasion, extra prostatic extension, and high-grade PIN in all the prostate cancer reports. The problem is subjectivity, especially when we talk about Gleason grading and Gleason pattern. There is a definite subjectivity, I mean, interpersonal variability, especially when you talk about pattern 3 and pattern 4. Some pathologists may call the same tumor as pattern 3, somebody else may call it as pattern 4. Similarly, tumor quantitation. I mean, quantitation presently is not done by measuring the tissue lengths under a microscope, but it is done by manual estimation. And another important problem is that in prostate, the number of slides are large. I mean, in a given case, trust-guided biopsy, there will be 12 to 14 cores of biopsies, that means 12 to 14 slides. And if a lab is a large volume lab with say 10 cases per day, will have 140, 150 slides to screen, which takes a lot of time. And in those screening large number of slides, we may miss sometimes very tiny foci of low-grade tumor, which are commonly seen in prostate, the grade 3 tumors, the Gleason pattern 3 tumors. So probably AI is an answer to this problem, and we will see how it happens. So at Dr. Lal Path Labs, we were the first one to acquire a clinical AI solution for prostate from IBEX, which is an Israeli company, and we acquired it in November 2021. And now we are using it to report all our prostate biopsy cases. This is how the interface looks like. And when you log into the interface, you will see the list of all the cases that are available to us for reporting with AI findings written in red or yellow, or if it is benign, then it will be written as benign in green. So when we can further deep dive and we can open each case, and then we can see that the whole slide image is available. And if we apply cancer heat maps on it, there will be some areas which are highlighted in red and some areas which are yellow and some are blue. Red indicates that there is high probability of cancer. So a pathologist has to just look at those areas which the AI highlights as red and confirm that there is cancer. I can apply another heat map which is called grading heat map, and you can see it's the same slide in same area of the tissue in all three images, but the heat map color is different because this is a cancer heat map and this is a grading heat map. In grading, blue indicates grade 3 cancer, while yellow indicates grade 4 and red indicates grade 5, which is not seen in this case. So it helps us in accurately grading the tumor also. AI tool will also help us in identifying the perineural invasion. This is the slide where perineural invasion has been highlighted by AI tool. I can confirm it by removing the heat map here, that there is actually a nerve fiber which has been surrounded by the tumor. Similarly, it helps us in accurate quantification of the tumor by actually measuring the length of the core and the length of the core where tumor is present, giving me exact percentage of tumor in each core. So, and this is how my report of prostate biopsy will go to the patient. It will contain on the first page all the heat maps, which are the relevant heat maps. And for each slide or each core, there will be a detailed report according to the CAP or ASCO guidelines. I also perform IHC in the cases where there is any suspicion, where even AI sometimes say that it is indeterminate for cancer. I can perform IHC as a reflex to that. Without any further billing or anything else. And after the IHC, I will give a confirmatory report in all such cases. This is an interesting case. Quickly, I will go through. This was a case with 12 slides. As you can see, that 11 slides are labeled as benign, likely benign by AI, while one slide is said indeterminate or cancer in yellow. So if I look at that slide, there was a very tiny focus which was highlighted by the heat map. I removed the heat map and saw that there were a few tiny glands. I am not sure whether these are cancer or benign glands. So I performed IHC, and you can see that these cells are positive for a marker and there is loss of basal cell layer by P63. So this case actually was acinar adenocarcinoma prostate Gleason grade 6, 3+3 involving only 1 out of 12 cores with tumor quantitation of only 3.6% involving that core. So this case, probably could have been missed if I did not have the AI available with me. This is a possibility. So AI helps me in AI diagnostic tools in prostate. They demonstrate excellent sensitivity and very high negative predictive value, making it a highly effective tool in ruling out cancer in low-risk patients and identifying true cancer cases. Now coming to breast, how it works in breast cancer. We are
Sir,
using...
sorry to interrupt you. Sir, please
Yes.
conclude in next few minutes.
Yes, definitely. So in breast, we are using it to report ER, PR, HER2, and Ki67 quantitation. And this is how it works. It counts the actual number of cells and the cells which are positive and gives us a percentage. This is HER2. And we presented a paper that using this tool, we have been able to reduce our HER2 equivocal cases from 15% to less than 8%, which is a direct impact on the cost to the patient because they won't require the FISH testing to confirm it. We are also using AI tools to report or to demonstrate metastasis in various cancer types, in the radical mastectomies and radical hemicolectomies and all those cases, and which again has significantly improved our accuracy. We presented a paper in US CAP conference on this also. The benefits of AI are improved accuracy and very high reproducibility. The future of AI includes that not only the structural changes, but the molecular signatures of the tumors will also be predicted by the AI tools. There are various AI tools now available, the foundation models, Virtuo, the Chief, which predict MSI, which predict even the response to immunotherapy or response to chemotherapy. Now, AI has to be taken with a pinch of salt, and we must use only the algorithms which are clinically validated and validated in our own laboratory also before putting it into clinical use, because AI definitely can make errors if it is not well trained AI solution. In the end, I would only like to end with this statement that humans are still the best suited for managing the creation of the new information, discoveries, new ways of approaching diagnosis, prognosis, and treatment, and can detect and deter AI-generated nonsense. But we also need help in getting through everlasting workload and accurately and efficiently reporting all these cases. And in these cases, AI will definitely help us. So to end with the statement by Dr. Stephen Hawking, success in creating effective AI could be the biggest event in history of our civilization, or the worst, we just don't know. So we don't know whether if we will be infinitely helped by AI, or we will be ignored by it, sidelined, and possibly destroyed by it. So thank you. And that's the place where I work. This is our National Reference Lab in Delhi. Thank you. Thank you very much once again, Dr. Mukesh, for this opportunity.
Thank you
I'll be happy to
so
take any questions.
Thank you so much, sir, for the enriching and insightful presentation. As your lecture was, you have covered almost everything. I was wondering if AI can help us in fast tracking the biopsy reports, like we have frozen sections. The report comes in 30 minutes, but there is a limitation because pathologists are not able to see, the cells are distorted, and you know
Right.
better technically. So can AI
Right.
help in this, that pathologist and AI can use these frozen sections and can give us with almost 99% accuracy the diagnosis within 30 minutes, within the patient getting operated, or the same day reports can start happening?
Yes, I mean, theoretically, yes, there is a possibility. Presently, I mean, AI is in very nascent stages wherein there are only limited number of AI tools available. But definitely, I mean, the thing that you are asking for, I mean, detection of cancer on frozen sections quickly. I mean, that is a very basic tool, and that can be developed in collaboration with various startups who are doing it. And yes, AI can definitely help. Otherwise, as I said, I mean, in prostate, it helps us in screening large number of slides very quickly. Similarly, we are planning to use AI in screening of pap smears. As I said, we are using AI in screening of large number of lymph nodes. So that helps us in fast tracking all the cases and early reporting of the cases also.
Thank you, sir. Thank you so much, sir, for the discussion. Now we move on to the last session of the day. I welcome Dr. Navdeep Singh Kelly. Dr. Navdeep is consultant medical oncologist and hemato-oncologist at Fortis Hospital, Jalandhar. He will be speaking on the next generation IO. What's different? Reinventing a better wheel in lung cancer with serplulimab. Over to you, Dr. Navdeep.
Thank you, Dr. Mukesh. Can somebody share my slides?
Daud Manya, can please share the slides. Manya, can you share the slides?
Yes, sir, sure.
Yeah.
Make it full screen. So today I'll be talking about this new immunotherapy, the next generation serplulimab. Next slide, please. So next slide, please. So talking about the esophageal cancer epidemiology in India, according to Global Count 2022, fifth most common cancer in India
and from both squamous and adenosquamous is the most common, accounting for almost 80% cases. Next. So now this drug serplulimab has been approved globally in the Europe for esophageal squamous cell carcinoma, non-squamous, non-small cell lung cancer, and in India it's approved in esophageal squamous cell carcinoma. While in China it has multiple indications. Next slide. So it's basically again it's a PD-1 inhibitor. It's a monoclonal antibody. Its structure again contain constant heavy chain, variable heavy chain, and a variable light chain. But this drug has a almost 10 times of more affinity than the our well-known immunotherapy drug nivolumab, and 3 times higher than the pembrolizumab. Next slide. So again, it again binds to the binds to the same epitope, but approaches PD-1 at a different angle because its chains contribute differently. It's a more complete binding and blockade than the other PDN1 inhibitors, and there are slow dissociation rates, and there is early T cell activation. So here is a little bit different mechanism of action. Next slide, please. So again, with this drug, serplulimab, there is more robust and rapid PD-1 internalization. And again, as we already know, the mechanism of all immunotherapy drugs. So it blocks co-clustering of CD28 with PD-1 during T cell activation compared to, and it's better than pembrolizumab. Next, please. So I'll discuss the phase 3 trial, which was Astrum-007 trial. So it was basically this first line serplulimab or placebo plus chemotherapy in PDL positive esophageal squamous cell carcinoma. Next slide, please. So just the outline, histologically confirmed cases of locally advanced or metastatic esophageal squamous cell carcinoma, PDL1 status should be positive, more than 1%. And there were two arms. Basically, in one arm, this immunotherapy was combined with cisplatin VFU, and then it was continued at a maintenance dose of 2 years compared with the placebo plus chemotherapy, and the primary endpoint was PFS. Next slide. So if you see, the PFS was better in the immunotherapy arm. It was 5.8 compared to the 5.3 month in the placebo arm. And specifically, if you see in the PDL1 positive with the CPS was more than 10, it was 7.1 versus 5.3 with a hazard ratio of 0.48. Next. And if you look at the overall survival, definitely there was a overall survival benefit with this combination arm, and the hazard ratio was even better when the more PDL1 positive with the CPS score of more than 10. Next, please. And if you see in this forest plot analysis, again, the benefit was consistent across all the subgroup, and it was favoring the immunotherapy arm. Next. Similarly, the OS benefit was again consistent across all the arms. Even if the PDL CPS less than 10, it's more than 10, favored the combination immunotherapy arm. Next slide, please. Even the objective response rate were more, and with the combination arm, it was 57.6 versus 42.1, and there were more CRs and PR in the combination arm. Next, please. Because this drug was very safely tolerated. The common side effects, again, well known to immunotherapy drugs like immune-related hypothyroidism, hyperthyroidism, and there were some neutropenias, anemias were there, but most of the side effects were tolerable. Next, please. Next, please. So, from the updated results from the ASCO 2023, after the median follow-up of 24.2 months, the median OS is 14.6 versus 11.2 with a hazard ratio of 0.70, and median PFS is also better with a hazard ratio of 0.58. Next, please. So these are the all phase 3 studies in which different immunotherapy drugs were used, and all the most of the phase 3 studies, the primary endpoint was PFS and OS. Next, please. So if you see, in most of the studies, if you see, the PFS and OS are quite similar, and this drug is performing quite well. Next, please. So coming to a conclusion, so combination with the chemotherapy, this immunotherapy drug, it produce consistent clinical benefit in OS, PFS, overall response rate, and with the manageable toxicity. So the efficacy is good with the drugs in the all the previously untreated or locally advanced or distant metastatic PDL1 positive esophageal squamous cell carcinoma. Next, please. So what about in the perioperative gastric cancer? Next, please. So again, the incidence of gastric cancer in India is rising. It's almost 7th most common cancer. Next, please. So we have data, initial data with 2 studies. One was the Keynote 585, in which the pembro was used as a perioperative setting, but the EFS was not met, so this trial was negative. Next, please. The other study is with the durvalumab Matterhorn. As we know, this is a global phase 3 study which showed a benefit. Next, please. So what about serplulimab in perioperative gastric cancer? Next, please. So it was a ASTROM-006 trial, again phase 3 trial, in which the combination of this drug was tested with oxaliplatin and S1. So again, after surgery, the adjuvant therapy serplulimab was continued compared to the chemotherapy. Next, please. So if you see in the PDL1 CPS more than 10 population, the median EFS is still not reached with the chemo plus placebo. It's 42 months. Still, it's favoring the immunotherapy arm. Next, please. And if you see the again in the PDL CPS more than 5 population, again the EFS is favoring the serplulimab arm with a hazard ratio of 0.73. Next, please.
Sir, can we request to conclude with your final key takeaways, sir?
Next, please. So again, coming to the conclusion, this again in the perioperative setting, if we use this drug and followed by the adjuvant monotherapy, it again significantly improve the outcomes again in the PDL positive patient, even if the CP is more than 5 or a 10 in the gastric or a gastric junction adenocarcinoma. Again, a well-tolerated drug, and there were very few discontinuation rate and the study regime. Next, please. So again, this is another phase 3 trial which is announced in which the this drug will be combined in the pancreatic ductal adenocarcinoma. This combination with this immunotherapy drug will be tested. Next, please. So again, coming to the summarize the thing again, in the combination of standard chemotherapy, cisplatin plus 5-FU, again it showed a significantly efficacy in the both in the form of PFS and OS with a manageable toxicity. So again, a new thing which is coming after durvalumab with this drug in the perioperative setting. And again, with in the new adjuvant setting, again the pathological complete responses which were achieved with this drug were 3 times higher, and it again met the primary endpoint of EFS. Thank you.
Thank you so much, Dr. Navdeep, for the wonderful
Thank you.
discussion. I
Thank
think
you.
with the availability of so many Indian immunotherapy drugs, it has become actually very affordable for the patients
Yes,
to
yes.
get the immunotherapy treatments, and it is actually a very good ray of hope for the patients. Thank you so
Definitely,
much.
definitely.
Thank
Thank
you,
you so
Dr.
much.
Navdeep.
So, Dr. Mukesh, sir, we come to the end of the day 1 of ONCOV Again. We request you to give your final conclusions, and then we close the session and invite everyone for tomorrow's session. Over to you, sir.
Yeah, so I will like to thank all the speakers, moderators, panelists, Our sponsors, pharma companies, the technical sport Horizon, for the wonderful conduct of the day one of the session. It was a enriching and insightful and learning experience. With so much happening in oncology, it actually becomes very difficult to keep abreast of the things, and conferences like this give us an opportunity. So closing for today, and I invite all of the faculty, all of our students to join for tomorrow's session, which we will be starting at 6 p.m. I think,
Yes, sir.
Tanvi.
Yes,
Yeah,
sir.
so we will be starting 6 p.m. tomorrow for the second session. We have very interesting topics lined up in GI, GIJU, and gynae oncology and pathology. So thank you, everyone. Thank you for joining
So,
today.
so on behalf of the complete organizing team, thank you so much, Dr. Mukesh, sir, for this wonderful evening. And on behalf of my colleague, Daud and Manya, we request you to stay safe, stay updated, and we meet you again tomorrow by 6 p.m. Looking forward for everyone's active participation. Thank you so much, and good night from all of us.